लाइव है। All right, hi guys. A very good evening to all of you. Welcome to the very first day of FMGE Predictor 2026. Now let me just quickly introduce to all of you guys what actually is FMG Predictor and how is it going to help you. This is going to be an entire 19 subject coverage of high yield topics from the FMG Predictor book that was recently launched by PW Meded platform. Now, in this section, I'll be discussing 5 ultra important topics that has been important not only from NEET PG, FMG, but also from the NEET PG point of view as well. Because as you all know that आपके examination में there are questions that are asked directly or indirectly from the NEET PG as well, right? So remember, this examination is a pure game of previous year topic, previous year question. We recently saw INICT examination as well, and in that examination also a lot of questions were directly or indirectly from previous year topics, and believe me or not, many questions were also from previous year topic, previous year question of FMG that has actually been asked in in your previous examination of 2021, 2022, 2023, right? So you have to balance your mindset. This examination is not just a 300 question that you are going to attempt, and out of 300 you are going to get, let's say, 150. It's the whole game of mindset. You have to believe in yourself. You have read it, you have revised it, you have given the GT, and you are reading it now one on one with me, with the other faculties after me. And believe me, once you have done all these, you have to have confidence that yes, once the question will come, I will be getting through this, right? Because mindset is everything for this examination. I mean 50% of the game is actually about mindset. आपको दिमाग से निकाल देना है कि मुझे चीजें नहीं आती हैं, मुझे चीजें भूल रही हैं। अगर भूल रही हैं तो मैं फिर से बोल रहा हूँ, ये बहुत ही अच्छी बात है, राइट? मैं इमीडिएटली स्टार्ट करने जा रहा हूँ, लेकिन माइंडसेट को लेकर के मैं बार बार बहुत क्लियर रहता हूँ कि एक्चुअल में एग्जाम देने से पहले आपको पहले अपने आप को जीतना पड़ेगा, अपने डर को जीतना पड़ेगा। यू हैव टू ओवरकम योर फियर्स, है ना? एंड देन ओनली यू विल बी एबल टू ओवरकम दिस एग्जामिनेशन, है ना? एक छोटे से बड़े फेमस लाइन के साथ स्टार्ट करूंगा। अभी रिसेंटली मैंने कहीं सुना था, कहीं बैठा हुआ था, किसी ने बोला और मुझे बहुत अच्छी लगी वो लाइन, तो उस लाइन के साथ स्टार्ट करूंगा कि निकाल लाया हूं एक परिंदे को पिंजरे से, है ना? आप वो परिंदे हो और पिंजरा ये माइंडसेट है ना? पिंजरा इज द माइंडसेट। तो निकाल लाया हूं एक परिंदे को पिंजरे से, अब उसके दिल से पिंजरे को निकालना है ना? आपको, अरे आपके दिल से इस डर को निकालना है। इस का एकदम शॉर्ट में अगर मीनिंग बताऊं तो यही है। स्टार्ट करते हैं, देखते हैं सबसे पहला हाई यील्ड टॉपिक क्या है। एक ऐसा टॉपिक जो कि अभी रिसेंटली आईएनआईसीटी में भी आया था, विच ऑफ द फॉलोइंग ड्रग इज नोन टू फॉलो कैपेसिटी लिमिटेड सैचुरेशन काइनेटिक शिफ्टिंग फ्रॉम first order to zero order at a higher therapeutic plasma concentration. I want your 1.5 to 2 hours of undivided attention. 50 क्वेश्चन, 50 हाई yield टॉपिक्स, हु नोज हाउ मेनी टॉपिक्स आर गोइंग टू बी आस्क्ड फ्रॉम हियर। तो आप और मैं एक वादा करेंगे कि अगले 1.5 से 2 घंटे आप कहीं नहीं हिलोगे, मैं कहीं नहीं हिलूंगा। मेरा तो गारंटी है, बिकॉज मैं तो लाइव हूं, लेकिन आपकी गारंटी आपको देनी पड़ेगी कि यस सर, हम आपके साथ हैं और इस पर्टिकुलर सेशन में हमें मैक्सिमम आउटकम के लिए आप बताओ करना क्या है। करना यही है, सिट बैक, रिलैक्स, लिसन टू मी। पीडीएफ क्लास के लास्ट में आप तक पहुंच जाएगा, चाहे जैसे भी पहुंचे। अगर नहीं पहुंचता है, आप मुझे डायरेक्टली कहीं से भी ढूंढ सकते हो, मैं इजीली अवेलेबल हूं, हर सोशल मीडिया प्लेटफॉर्म पे आपको मिल जाएगा, राइट? सवाल का जवाब, जैसे सवाल आए सवाल का जवाब दीजिए। विच ऑफ द फॉलोइंग इज फॉलोइंग zero order at the higher plasma concentration? The answer for this one is going to be drug like your phenytoin. Please remember, phenytoin, it is one of the anti-epileptic drug, point to be noted number 1. It is one of the voltage gated sodium channel blocker, point to be noted number 2. Its therapeutic plasma concentration, remember the therapeutic plasma concentration of phenytoin, it is going to be 10 to 20 microgram. Therapeutic plasma concentration 10 to 20. And a very important point that you should know, a very important point that you should know, that beyond 20 microgram, remember beyond 20 microgram they start following zero order kinetics. इसके बाद से they start following zero order kinetics. Up until therapeutic plasma concentration they are actually following first order kinetics. They are actually following first order kinetics. अब चूंकि हम लोग ये हाई टॉपिक डिस्कस कर रहे हैं, मेरी जिम्मेदारी बनती है कि इससे जो क्वेश्चन आए हुए हैं पिछले 2 से 4 सालों में उन पे बात कर लें, और आने वाले पोटेंशियल एमसीक्यू क्या हो सकते हैं उस पे बात कर लें। तो फेनिटोइन से रिलेटेड एक रीसेंट क्वेश्चन जो आया था वो इसके इंपॉर्टेंट साइड इफेक्ट्स से आया था। इट इज एक्चुअली एसोसिएटेड विद द गम हाइपरट्रॉफी, ऑल्दो इसके अदर भी बड़े सारे साइड इफेक्ट होते हैं, गम हाइपरट्रॉफी, राइट। इट इज ऑल्सो एसोसिएटेड विद सम इंपॉर्टेंट इलेक्ट्रोलाइट इंबैलेंस। तो लेट मी टेल यू, इलेक्ट्रोलाइट इंबैलेंस में बड़ी सारी बातें आएंगी, लेकिन आपको ध्यान रखना है कि इलेक्ट्रोलाइट इंबैलेंस में क्या क्या हो सकता है वो आपको ध्यान रखना। ध्यान रखिएगा, एक तो इट कैन कॉज हाइपोकैल्सीमिया, एंड अदर वन दैट यू शुड नो इज कॉल्ड हाइपरग्लाइसीमिया। हाइपरग्लाइसीमिया, तो डायबिटिक में यू शुड बी वेरी वेरी केयरफुल, ऑल्दो इट इज हैविंग लॉट ऑफ साइड इफेक्ट, बट आई एम नॉट गोइंग ऑन दैट। जैसे कि मैंने बताया, हमें टू द पॉइंट रहना, फोकस्ड रहना है, 1.5 to 2 आवर्स के लिए फोकस रहना और देखना है कि कितने हाई यील्ड इंफॉर्मेशन हम इस पर्टिकुलर सेशन से निकाल पाते हैं। Phenytoin is the high yield topic. Remember, it has been asked. It can be asked all over again. Okay, coming back again to the topic. Remember, it is following first order kinetics from 10 to 20. Beyond 20, it is start following zero order kinetics. So sometime it is also known as the drug that is following pseudo zero order kinetics. अभी recently INICT जो एग्जाम हुआ था, I'll tell you, in the INICT examination, what they gave a graph and they just asked to recognize, and I always say this कि देखिए जीरो ऑर्डर फर्स्ट ऑर्डर में क्वेश्चन आ चुका है, अपकमिंग एग्जामिनेशन में they will just give the graph, and we got so lucky this time that we got the same graph that are actually being discussed in our actual classes, and it has been discussed everywhere. You go open KDT, you open any particular book, see, whenever we talk about first order, remember the fraction of elimination is constant. So in the very first half life, remember there is sudden fall in the plasma concentration, sudden fall, 100 से plasma concentration immediately half हो जाएगा, and then it will keep on decreasing every time, and in the first order there will be falling curvy linear graph. So this was the question, I'm just showing you INICT में अभी मई में जो एग्जाम हुआ था उसका क्वेश्चन है ये, this was the question. And in the zero order, remember zero order, the plasma concentration that is falling, it's actually following a linear fall, right? It's actually following linear fall, because in zero order, remember, the amount of drug that is being eliminated is actually going to be constant, right? Amount here, the fraction of the drug that is being eliminated is actually going to be constant. Fraction means 20%, 50%, 30%, something like that, right? All right. Yes, I'll take care of that. Don't worry. So that is actually one of the recent question that was asked. I hope that all of you guys have got, and we have covered some of the important areas from this one. Now remember, all others are actually following first order kinetics among the given image, among the given option. Next question. A patient is being treated with haloperidol. Second question, ultra important topic. देखिए हम शिफ्ट हो चुके हैं ऑलरेडी सेकंड इंपॉर्टेंट टॉपिक पे. Haloperidol, it's a D2 blocker. It is known as your typical antipsychotics. It is known as what? Typical antipsychotics. They actually develop rigidity, bradykinesia, and tremors. Okay, so rigidity, bradykinesia, and tremor, don't you think they are sounding like Parkinsonism? Yes. Which of the following drug is most appropriate for the management of this condition? All right, so now the patient has actually developed something called your extra pyramidal symptom like dystonia, akathisia, secondary Parkinsonism. These are all extra pyramidal symptom. Now question number 1 that has been asked, right? One question, extra pyramidal symptom developed due to which pathway? So they actually developed due to D2 blockade in which pathway? So remember, question number 1, they are going to be associated with nigrostriatal pathway. Nigrostriatal pathway, they are very very high yield topic. जैसा कि मैंने बोला कि आपको बस अर्जुन की तरह सही जगह पे निशाना लगा के रहना है, राइट? मैं बताता जा रहा हूं, आप एक एक बार मेरे साथ ब्रश अप करते जाओ. ड्यू टू विच पाथवे? दैट इज गोइंग टू बी नाइग्रोस्ट्रिएटल पाथवे. दैट इज वेरी वेरी इंपॉर्टेंट. हाउ विल यू मैनेज इफ द एक्स्ट्रा pyramidal symptom? See, extra pyramidal symptom develops why? Because the dopamine is blocked, and because of the excessive dopamine blockade, जो नॉर्मल डोपामीन और एस्टाइलकोलिन का बैलेंस है, दैट हैज बीन इम्बैलेंस्ड. सो इन दैट केस सिनारियो, व्हाट यू आर गोइंग टू डू, यू हैव टू एक्चुअली ट्रीट देम बाय गिविंग सेंट्रली एक्टिंग एंटीकोलिनर्जिक ड्रग. सेंट्रली एक्टिंग एंटीकोलिनर्जिक ड्रग दैट यू कैन यूटिलाइज, ड्रग्स लाइक योर benzaxole, benztropine, benzaxole, benztropine, right? There are other drugs that you can use. For example, drugs like your promethazine, that is antihistaminic drug having anticholinergic property, that can also be utilized. Remember that. Okay. Now First, let me just finish the answer to this question. It is actually going to be what? It is actually going to be what? It is going to be बेंसेक्सुअल. जैसे ही सवाल आए जवाब इमीडिएटली आना चाहिए. सवाल आए जवाब आप फेंक के मारो, है ना. डोंट गेट कंफ्यूज इन द ऑप्शन. मैं चाहता हूं कि व्हेन यू सी द क्वेश्चन हंट डाउन द ऑप्शन. और ये तभी पॉसिबल है व्हेन यू आर एक्चुअली इनफ प्रैक्टिस्ड. जीटी हो गया या ऐसे 1-to-1 सेशन हो गए या आपने खुद जो सेल्फ स्टडी किया वहां से, राइट. सो एक्स्ट्रा पिरामिडल सिम्टम को पहचानना बहुत आसान है, राइट. डिस्टोनिया, एकैथीसिया, राइट. लेट मी जस्ट क्विकली डू द समरी ऑफ दैट एज वेल. The most common extrapyramidal symptom, it is going to be akathisia. That is point to be noted. Number 1, my lord, akathisia. Remember, the drug of choice for this is going to be propranolol. Then earliest extrapyramidal symptom, what is the earliest extrapyramidal symptom? Earliest is going to be dystonia. Abnormal tone, right. They can actually be treated by again the same centrally acting anticholinergic drug, benztropine, benzhexol, right. Then the dangerous extrapyramidal symptom, which one is called dangerous extrapyramidal symptom? The dangerous extrapyramidal symptom, it is going to be your neuroleptic malignant syndrome, right. So this is everything about the important topic. तो जैसा कि मैंने बोला कि हमारा निशाना सही जगह पे होना चाहिए, राइट. तो एक्स्ट्रा पिरामिडल सिम्टम के बारे में जो भी हाई यील्ड टॉपिक्स है हमने यहाँ कवर कर लिया. प्लीज रिमेंबर, यू विल नॉट लीवोडोपा हियर, लीवोडोपा, ब्रोमोक्रिप्टिन इज अ D2 एगोनिस्ट. बेंजेक्सुअल, यहाँ पे ऑलरेडी हमें डोपामिन का लेवल ऑलरेडी कम हो गया, हमें बेसिकली जो एस्टाइलकोलिन का लेवल ऊपर चला गया है, हमें उसको नीचे लेकर आना है. सिंपल सी बात है, राइट. फॉर दैट वी विल बी यूटिलाइजिंग सेंट्रली एक्टिंग एंटाइकोलिनर्जिक ड्रग. देयर इज नो रोल ऑफ गिविंग बीटा ब्लॉकर और डोपामिनर्जिक ड्रग हियर. ओके, क्लियर है. We proceed with the next one. So the next high yield topic, I mean, you can consider this as an anesthesia topic as well. All of the following are amide local anesthetic except. देखिए इसको आसान, सबसे आसान क्वेश्चन ये वाले होते हैं. एनेस्थीसिया से 3-4 क्वेश्चन जो उनके फेवरेट हैं. एक, द लेयर विच इज पियर्सिंग, है ना. लेयर्स जैसे स्किन हो गया, सबक्यूटेनियस टिश्यू हो गया, राइट. ये जो ड्यूरा मैटर को पियर्स करते हुए आगे बढ़ता है, तो लेयर्स वाला एक क्वेश्चन उनका रहता है, वो ऑल टाइम फेवरेट रहता है. लोकल एनेस्थेटिक का मैकेनिज्म ऑफ एक्शन रहता है, राइट. देन दे आर आल्सो आस्किंग द मसल रिलैक्सेंट, नॉन डिपोलराइजिंग एंड डिपोलराइजिंग मसल रिलैक्सेंट, राइट. लोकल एस्टर और एमाइड में डिफरेंस. तो ये कुछ इनके फेवरेट टॉपिक है, इनमें से एक आध रहते ही रहते हैं, राइट. हर बार के एग्जाम में देख लीजिए. नाउ ऑल ऑफ द फॉलोइंग आर एमाइड. देखिए एस्टर को कैसे पहचानते हैं. एस्टर इज अ फेस्टिवल विच इज एक्चुअली सीन वंस इन अ ईयर, राइट. तो एक्स्टर में देयर विल बी 1 आई एंड एमाइड में देयर विल बी 2 आई. तो इट इज आस्किंग ऑल ऑफ द फॉलोइंग आर एमाइड एक्सेप्ट. तो इफ यू सी देयर इज आई हियर आल्सो. आई. Cocaine is the one that is going to be, right. Cocaine is the one that is going to be from the other group. They are not amide, they are the extra group, right. So this was a very easy peasy question, I believe. Next one, a 32-week old local anesthetic का mechanism of action जैसे मैंने बताया था. Mechanism of action, they act by blocking sodium channel. In fact, in one of the examination they gave the image, and in that there was sodium, potassium, all those. So they said कि at which area it will be working. So you just have to choose sodium, है ना. सोडियम पे आपको सेलेक्ट करना था. A 32-week pregnant female presents with a blood pressure of 175. Okay, 32-week pregnant female. So 32-week pregnant female का मतलब ये हुआ कि there is a female who is pregnant and currently she is on 32nd week age of gestation. बात समझ गया. इसका कोई दूसरा मतलब मत निकलिएगा, ठीक है, बिकॉज बच्चे निकालते रहते. तो विद द ब्लड प्रेशर 175, 115 and generalized tonic-clonic seizure है, which of the following the drug of choice to control this seizure. Okay, so there is no past history there. It's just saying okay, in the 32nd week she is getting the seizure. Why? Because look at this, there is the eclamptic seizure, right. Eclampsia, right. This is called eclamptic seizure, right. And drug of choice for eclamptic seizure is what? जैसे ही सवाल आए जवाब आना चाहिए. सवाल का जवाब सवाल में ही होता है ना. जैसे कि एक शायर ने बड़ी अच्छी बात बोली है, ख्याल जिसका था मुझे ख्याल में मिला मुझे, ख्याल जिसका था मुझे ख्याल में मिला मुझे, और सवाल का जवाब भी सवाल में मिला मुझे. आपके पास सवाल और जवाब दोनों दिया है. एग्जामिनर बोला है बेटा सवाल ये है जवाब ये है, आपको सेलेक्ट करना है. एक सेलेक्ट कर लो बस, बात खत्म, राइट. यहाँ पे कौन है, यहाँ पे इसका करेक्ट आंसर होगा eclamptic seizure, drug of choice for eclamptic seizure, it's actually going to be eclamptic seizure. It's actually going to be your सोडियम वैल्प्रोएट, सॉरी मैग्नीशियम सल्फेट. सोडियम वैल्प्रोएट क्यों आया मैं बता रहा हूं आपको. सोडियम वैल्प्रोएट इट्स एक्चुअली अवॉइडेड बिकॉज दे आर एक्चुअली एसोसिएटेड विद अ वेरी इंपॉर्टेंट टेराटोजेनिक इफेक्ट दैट इज कॉल्ड स्पाइना बाइफिडा. स्पाइना बाइफिडा का इमेज आपके एग्जाम में आ सकता है. देखिए, क्योंकि गम हाइपरट्रॉफी ऑलरेडी पूछा गया है, तो मैंने बोला था गम हाइपरट्रॉफी का इमेज हो सकता है, गम हाइपरट्रॉफी का इमेज और स्पाइना बाइफिडा का इमेज, जिसमें दे कैन गिव यू एक बेबी रहेगा, है ना, एक बेबी का ऐसे इमेज रहेगा, and there will be exposed spinal cord, maybe covered with a tuft of hair, something like this will be an image, and they will ask which of the following anti-epileptic drug is responsible for this. So most commonly it could be associated with the sodium valproate. Among the anti-epileptic drug, remember, they are considered as the most teratogenic anti-epileptic drug. They are the most teratogenic anti-epileptic drug. All right, most teratogenic. Phenytoin actually is avoided also in the pregnancy because phenytoin as a drug, they are going to be associated with a very famous problem that is called fetal hydantoin syndrome. Fetal hydantoin syndrome. Fetal hydantoin syndrome. ठीक है, fetal hydantoin syndrome. All right, remember that. So in this case scenario, eclamptic seizure. Now, because this is a case of seizure during pregnancy, I will take this opportunity very quickly to tell you what is the drug of choice for epileptic disorder. Epileptic disorder in pregnancy. Epileptic disorder in pregnancy. So drug of choice is actually going to be levetiracetam. Epileptic disorder क्या होगा? लेवेटिरासेटाम. क्या आप रेडी हैं अगले 1.5 से 2 घंटे के लिए? अभी तक किसी ने कंफर्मेशन नहीं दिया. यस सर, वी आर रेडी टू टेक दिस रोलर कोस्टर ऑफ फार्माकोलॉजी एंड वी वांट टू ascertain that all the high yield topics have been brushed up once in front of our eyes. लाइव क्लास में आपके साथ हुआ था, राइट. लेवेटिरासेटाम एंड ब्रिवारासेटाम. जल्दी से रिप्लाई करिए कि क्या आप तैयार हैं अगले 1.5 से 2 घंटे के लिए ये पढ़ने के लिए कि क्या हाई यील्ड टॉपिक है, यस और नो. ड्रग ऑफ चॉइस फॉर एपिलेप्टिक डिसऑर्डर इन प्रेगनेंसी इज गोइंग टू बी लेवेटिरासेटाम, ब्रिवारासेटाम. ये होते क्या हैं? विच क्लास ऑफ ड्रग आर दे? सो दे आर, रिमेंबर, SV2A इनहिबिटर. व्हाट आर दे? दे आर एक्चुअली नोन एज योर SV2A इनहिबिटर. नाउ, जैसा कि मैंने बोला, आई विल नॉट मिस दिस अपॉर्चुनिटी टू टेल यू ऑल द हाई यील्ड टॉपिक्स जो मैं एक्सपेक्ट कर रहा हूं एपिलेप्टिक डिसऑर्डर में. आप उसको गायनी का क्वेश्चन मान लीजिए, फार्मा क्वेश्चन मान लीजिए, डजंट मैटर. इसके साइड इफेक्ट को मैं एक्सपेक्ट कर रहा हूं, पिछले 2 बार से एक्सपेक्ट कर रहा हूं, नहीं आया है. कई बार 2-3 बार एक्सपेक्ट करने के बाद भी अगले एक्सपेक्टेशन में आ जाता है. हु नोस, राइट. सो वी जस्ट ट्राई टू डिस्कस द हाई यील्ड टॉपिक एंड वी सी क्या क्या चीजें हो सकती हैं ओनली ऑन द बेसिस ऑफ द प्रीवियस क्वेश्चन दैट हैज बीन आस्क्ड. इंपॉर्टेंट साइड इफेक्ट. द मोस्ट कॉमन साइड इफेक्ट इज गोइंग टू बी somnolence because of its pro-GABAergic property. They actually increase the level of GABA as well. SV2 inhibitor. Somnolence is the most common side effect. Other side effect is going to be anger, एजिटेशन. अगर आपने कभी भी मेरी फार्मा की क्लास करी है तो एक बीवी वाली कहानी जरूर सुनी है, और अगर आपने सुनी है तो जल्दी से कमेंट में बताइए क्या है वो बीवी वाली कहानी, अगर आपको याद आ रहा है तो. एंगर, एजिटेशन, एग्रेशन. किसी को याद आ रहा है तो जल्दी बताओ. एंग्जाइटी, इजी इरिटेबिलिटी. एक बीवी की कहानी में बताता हूं, राइट. बीवी वाली कहानी याद आ रहा है कि नहीं? यस. कैन बी ऑल्सो यूज lamotrigine. Yes, the alternative to this, alternative drug of choice, alternative drug of choice in pregnancy could be lamotrigine. See, no drug is 100% safe, but when you are comparing the problem with drugs like let's say valproate or phenytoin, they are relatively much safer, right. Alternative in pregnancy is going to be, alternative drug of choice is going to be lamotrigine. Drug of choice currently is going to be levetiracetam, brivaracetam. किसी ने बताया बीवी वाली कहानी? I could not see the comment. याद आ रहा है? यस, वेरी गुड. चलिए मैं बता दे रहा हूँ कैसे याद करना है, बिकॉज ये बार बार क्वेश्चन आता रहता है आपकी एग्जामिनेशन में. तो लुक एट दिस. SV, मेरे साथ प्लीज रिपीट करिए और अभी याद करिए इसको. बोलिए SV लीवी, लेवेटिरासेटाम. SV लीवी. बोलिए मेरे साथ, जहां कहीं भी हैं बोलिए, बोल के पढ़ेंगे और इसको अभी खत्म करेंगे. SV लीवी, विच साउंड्स लाइक अ बीवी, ब्रिवारासेटाम. और बीवी के लिए क्या हम नहीं चाहते हैं कि सब कुछ सेफ हो, सब बेहतर हो? तो बीवी स्पेशली अगर प्रेगनेंसी में हो, राइट. इफ द बीवी इज इन प्रेगनेंसी, रिमेंबर वी वांट द सेफेस्ट ड्रग. सो ओके, रिपीट. SV लीवी साउंड्स लाइक अ बीवी. बीवी मींस वाइफ. बीवी इज wife. In English also I'm telling you BV is wife. SV, Levy sounds like a BV, and you imagine a BV, imagine a wife, right? In pregnancy, if she will take it, she'll be sleeping most of the time. The most common side effect is somnolence, and when she gets up. Anna, have you seen the Hindi movies, the drama serials, right? When she get up, she does what? Usually angry, agitated, aggressive usually. On whom? On the poor husband, anxious also, and easily irritable. So you just have to imagine one BV and you'll be able to solve all these important problems of SV2A inhibitor or drug of choice for pregnancy, epileptic disorder in pregnancy, SV, Levy, sounding like a BV, levetiracetam, brivaracetam, right? And everything else. Remember the all the important distinctive features of a BV that is shown in the Hindi movies or the drama serials, right? So that is going to be anger, agitation. मैं अपने personal experience से बिल्कुल नहीं बोल रहा हूँ. Please do not think I am telling this from my personal experience, because even my wife also watches YouTube sometimes, so I cannot say anything here, Anna. And if you can understand the symbol that okay, I need some help, you understand that, right? Okay, coming back, jokes apart, we'll go to the next question. So you got this question here, that safer alternative is, safer drug for epileptic disorder in pregnancy is going to be SV2 inhibitor. Alternative safe drug is lamotrigine. Magnesium sulfate is actually, if it is eclampsia induced seizure, right? High blood pressure, proteinuria, and seizure, right? That's called eclampsia. Can we take the next one? Yes. The next one, a patient with rheumatoid arthritis developed megaloblastic anemia. Yes, I'll take care of the English. Yuki, I got that in the very first time itself. We'll take care of the English language. A patient with rheumatoid arthritis developed megaloblastic anemia after initiation therapy. Which drug is responsible? Okay, so since they're asking here about rheumatoid arthritis, remember rheumatoid arthritis, the drug of choice for rheumatoid arthritis is methotrexate. It's the drug of choice in rheumatoid arthritis. It's a drug of choice in rheumatoid arthritis. All right, it's one of the dihydrofolate reductase inhibitor, and they interfere with the activation of folic acid even inside the body as well, and they are actually going to be associated with megaloblastic anemia. They're actually associated with megaloblastic anemia, right? Megaloblastic anemia and bone marrow suppression. This is a very important problem with the methotrexate, right? Very important problem with the methotrexate, and it's a very commonly utilized drug. Believe me, very commonly utilized. It is having a lot of anti-cancer property as well, and it is utilized in rheumatoid arthritis and multiple other conditions. Okay, so for targeting these kind of abnormalities like megaloblastic anemia and bone marrow suppression, remember, and they are also associated with a lot of hepatotoxicity. They are also associated with lots of hepatotoxicity. Yeah, highly hepatotoxic. So you should always keep an eye on the LFT. You should always keep an eye on the LFT. All right. So this is actually to prevent this, right? To prevent these kind of problem, the methotrexate mediated problem, you have to add usually something called your folinic acid. You have to add what? Folinic acid. Folinic acid, right? Folinic acid. Other name of the folinic acid is leucovorin. Now remember, many of you, when you see a question like this, you jump with the very first or second option, and you have to understand that this session is not only going to give you the high yield topic, but also the insight about how to approach a question, right? Because when you see the question, you try to jump on a conclusion immediately. You must have heard somewhere megaloblastic anemia and folinic acid, and many students will say, okay, look like folinic acid, look like megaloblastic anemia, they'll jump for the folinic acid. But remember, that's a wrong statement, right? The correct answer for this one is going to be your methotrexate. I hope it is making sense to all of you, and I hope it is done, and we have taken this question. All right. Certolizumab, it's a monoclonal antibody, hydroxychloroquine. It's one of the drug that is associated with bullseye maculopathy. This is also one of the PYQ, bullseye maculopathy. Chloroquine ka hydroxylated analog. It's a hydroxylated analog of the chloroquine. All right, moving on to the next one. The next high yield topic is how will you recognize this? In your examination, they will not be giving you patient of rheumatoid arthritis. Believe me, they'll never be giving you patient with rheumatoid arthritis. Then you will be asking, sir, then why have you given? See, har cheez hum bata denge. Agar if I write everything, then what is the purpose of me coming here, right? So the examiner ka mindset is they should not be giving rheumatoid arthritis. Rather, they'll be giving you early morning joint stiffness. What is the clinical picture? So patient with early morning joint stiffness. If the examiner is in good mood, they might give you some image that is quite similar to this, and this is called your swan neck deformity, that is being discussed in your examination in your class as well. Swan neck deformity, where there is actually flexion of the DIP, distal interphalangeal joint, hyperflex. This is a proximal interphalangeal joint, this is going to be hyperextend, right? So this is called your swan neck deformity. So if the examiner is in good mood, they can give you image as well, and they're very easy to recognize. Although I cannot make swan neck deformity, right, but there will be something like this. You can easily see this one, swan neck deformity, or other one is called boutonniere deformity. The quite reverse of the same is going to be boutonniere deformity, right? So these kind of question may be asked in your examination, and the clinical picture will be given. Please remember, the question will not be saying patient with rheumatoid arthritis, patient with the early morning. There will be history of a young girl, young lady, 20, 25, 30-year-old young lady with early morning joint stiffness, and they may give you the image something like this, right? And they will ask you what is the drug of choice, or they may ask you that what is the drug that will be added. If you are solving one of the PYQ book of FMG, you must have seen all these questions already. Next is atorvastatin should ideally be administered at what time? Now, what are the questions that could be asked from this topic? I'll quickly brief it out in this one. So that is what we are doing. 50 questions, 50 high yield topic. That's it, right? And how much time did I ask? Only 1.5 to 2 hours, and that's it. Our entire thing will be sorted. All right. So atorvastatin, question number 1. Atorvastatin, remember, it is one of the HMG-CoA reductase inhibitor. HMG-CoA reductase inhibitor. Right, HMG-CoA reductase inhibitor. These are actually going to inhibit the rate limiting enzyme HMG-CoA reductase, right? And remember, the dosing of HMG-CoA reductase inhibitor, it is usually advised. The dosing usually advised at night time. Now, according to chronopharmacology, the majority of cholesterol synthesis is happening between 12 to 2, right? So the dosing is advised usually at night time, but drugs like atorvastatin, rosuvastatin, they are longer acting, so we can give them anytime. But still, the physician prefer to give them at night time. Reason being, I told you, the chronopharmacology. Chronopharmacology means timing ke according, the pharmacological effect according to the timing of the drug, right? So the majority of the cholesterol synthesis is happening in the night between 12 to 2. So in that case, we will be giving usually in the night time. Another point that you should know, that with the meal, this is one of the example of the drug with the meal, especially fatty meal, the absorption of this statins, like this atorvastatin statins, the absorption of statins actually increases. So you have to give after the meal, not before meal, right? So 30 minutes before the meals, empty stomach, dono ka matlab same ho, the meaning A and B same. With milk usually interfere with the absorption, right? Here at bedtime, that means after the meal. Always to remember, after the meal. This is one of the example of the drug, the absorption of statins increases. Now you might be asking, sir, what are the other examples? There are so many examples. Do you have to remember all of them? No. With the meal, absorption is increase for drug like your griseofulvine. This is another example. Griseofulvine, statins, and tyrosine kinase inhibitor. I always say GST, and GST, the GST that is being taken by our government, and that can absorb anytime, and especially after the meal, so definitely, right? So the correct answer for this one is going to be at bedtime. Now, what are the other potential topic from HMG-CoA reductase inhibitor like statins? Remember, the important side effect of statins are always a hot topic for the examiner. They are going to cause myopathy. Now, this myopathy could be a simple myalgia. This could be a simple myalgia to a life-threatening condition that is called rhabdomyolysis. Life-threatening condition that is called rhabdomyolysis. The rhabdomyolysis risk is actually increased. With rhabdomyolysis, risk is going to increase usually with the enzyme inhibitor, right? Enzyme inhibitor, so the risk will further increase. Remember, other important side effect of this will be hyperglycemia. That is another important side effect. Hepatotoxicity. there is another going to be important side effect. Remember that, right? So statins are associated with all these important side effects. I hope that statins ke sath we have done some justice. As I told you that we have to be very, very particular. If you go any left and right, the duration will be very, very long, and the entire essence of doing this series will be lost, because we have done a lot of longer session, 4-hour session, 5-hour session, and sometime even 70-80-hour session as well, right? That is in different sessions, but we have done that. But this one is, we have to be very, very focused, and as I said, 1.5 hours, that's it. Next one. A patient with HIV is being treated with a regimen including tenofovir, all right? Tenofovir. So we have to cover all the high yield topics related to this. Which of the following is the characteristic adverse effect related to this drug, right? Which of the following is the characteristic adverse effect? Now, what I say, learn pharma in my style. Sit back, relax, listen to me. Question number 1. Tenofovir is which group of drug? Tenofovir is a highly effective drug. Tenofovir is a highly effective drug. Remember, guys, this is one of the nucleotide reverse transcriptase inhibitor. Tenofovir is what? Nucleotide reverse transcriptase. Very, very important. Nucleotide reverse transcriptase inhibitor. It is one of the competitive inhibitor of the reverse transcriptase enzyme. Very, very important. Examiner is fond of asking whether they are competitive or non-competitive, right? So that is point number 1. It's the very, very effective drug that can be utilized in HIV and can also be utilized in hepatitis B virus. Look at this, highly effective drug. And which of the following antiretroviral drug is very much effective, very much preferable in hepatitis B virus? The name of the drug is in front of you, boys and girls. That is going to be tenofovir. Tenofovir is one of the drug that is nucleotide. Now, learn pharma in my style series may listen to me carefully. Tenofovir, it breaks your bone and also affect your kidney. So I say ये तोड़ देता है. तोड़ना is breaking, right? For my English speaking student, तोड़ना is breaking. तो ये तोड़ देता है क्या? Bone. It is going to affect the bone, and it can also cause tubulopathy, right? So they are actually associated with tubulopathy. Now this tubulopathy can actually lead to calcium and phosphate loss. And because of that, there will be increase in the fracture. You see how simple it is, right? And they can even be leading to something called your Fanconi syndrome. And remember, as I told you, that ये तोड़ देगा bone को, and it can even cause tubulopathy. It can even cause tubulopathy, right? Renal failure can also be seen because of the Fanconi syndrome. Even acute renal failure can also be seen. Remember, the name of the drug is called tenofovir, which is a competitive inhibitor. Among the given choices, the correct answer is going to be, right, Fanconi syndrome. Sir, will the recorded version of the video will be available? I hope so. Let's hope, है ना? Let's hope. But आप अपनी कोशिश जारी रखिए, है ना? आप अपनी कोशिश कैसे जारी रखेंगे? You have to sit back, relax, continue, finish this one along with me. But at any given point, if it is not there, then at least you have done this one, right? You'll get the PDF for sure, but I think video should also be there. There is no video that I see that the platform removes, so video should be there. But until I don't have a specific information from the team, I cannot commit anything, but it should be there. Ideally, ज़्यादातर chance है it should be there, right? Next question. So we are done here, right? And अगर मुझे इसमें एक और बात बोलनी होगी, if I have to cover one more topic, then remember the most preferred regimen that we have currently for the treatment of HIV. I think all my students are already aware. This is going to be TLD, tenofovir, lamivudine, dolutegravir. That is going to be what? Tenofovir, lamivudine, and other one is called your dolutegravir, right? So tenofovir 300, lamivudine 300, dolutegravir is something called your 50 milligram, right? Once daily it is given. Once daily it is actually given. So I hope that it is making sense to all of you guys. Preferred regimen for HIV is going to be TLD regimen. Moving on to the next question. All right. A patient is having spina bifida after maternal intake of Valproate during the pregnancy. Okay, I think a while ago I just told you that spina bifida is actually associated with Valproate. Now, this time they are not asking which drug is causing spina bifida. This time they are asking what? They are asking which type of ADR is it. In the ADR classification, there are A, B, C, D, E, right? So which type of ADR, is this? Remember, anyone can tell me? Anyone can tell me? Which type of ADR that you guys can think? All of you, many students are live and the comment is very sluggy. You just waiting. Okay, anyway, you are going to tell the answer. We just want to simply listen to the answer. I want your active participation. I want you to make mistake. The more mistake you make, the finer you are going to become in the class, right? You are going to make mistake in front of almost 100 people, right? Those who are listening to you, and even after the class also many people will be watching recorded as well, right? So you have to be very, very attentive and you have to interact. The more you interact, the more you will learn from me. Believe me, I can promise you that. What's the answer? Many of you are saying C, B, D, A also. So I mean, the population is totally divided in all four direction, all four options, right? Which adverse effect? All right. So you see, at this point of time, when the person consumed the drug, let's say this is the start point of consuming the drug, they are saying there is no problem, right? Maternal intake of valproate. So the mother took the drug here, there is no problem. Then she continued the drug as throughout the pregnancy, there was no problem. Maybe at any given point she stopped also during the pregnancy. Someone has asked to, shift to a safer alternative. Okay, she stopped. Another again there was no problem. When did the problem arise? The problem actually arise after the birth of the baby, after some month, after a few weeks or few months, right? So here the problem is arising here. You have stopped the drug. Even after stopping, even immediately after stopping, it's not coming. If the ADR is coming just at the point of starting, so I say it could be type A or type B. It could be type A or type B. If the adverse drug reaction is starting, it is seen just at the time of starting the drug, that will be type A and B. Like for example, A is going to be augmented kind of ADR. A is going to be augmented kind of ADR. Augmented kind of ADR. A is going to be augmented. A, and this is B actually. B. B is going to be bizarre, right? You cannot explain this with the mechanism of action of the drug. A can be explained by the mechanism of action of the drug. C is going to be the chronic upon prolonged intake. It's actually going to be seen upon prolonged intake. For example, you have taken prolonged NSAID. For let's say week or month, and now you have developed peptic ulcer disease. Type D is called delayed kind of ADR. So this is actually an example of delayed kind of ADR. Correct answer for this one is D. As a matter of fact, all the teratogenic effects are type D kind of ADR. All the teratogenic effects are type D ADR. Teratogenic, whatever that they are going to be type D, delayed kind of ADR. A augmented, what is the important example? As I told you, type A can be explained by the mechanism of action of the drug, and they are quite predictable ADR as well. They are very much predictable. For example, if I ask you and if I tell you the story of a village where patient went to city, and that city was quite far from the village. Let's say that was somewhere around, this is a true story actually, somewhere around 15 to 20 kilometers. There she was diagnosed with diabetes and the HbA1c level was very, very high, and the physician started her on insulin, and insulin was, let's say, was started according to her weight. It was started, and it was, I think, around 10 units. Imagine if she was advised for 10 unit, and instead of giving 10 unit, if someone is going to give her 10 ml, then what will happen? What is gonna happen? It is a dose dependent predictable ADR. If I tell you that insulin was advised for 10 unit, but if she is given high dose, right, high dose of insulin, that high dose of insulin can actually cause what kind of ADR? What you can predict, what kind of problem it can cause? So insulin can actually lead to what? Hypoglycemia. It's actually hypoglycemia that you can predict. Or I can tell you, if I'm going to give beta blocker, I gave beta blocker, let's say 20 milligram, but patient consumed 20 milligram 3 tablets, that is totally going to be 60 milligram. That means high dose of beta blocker. What kind of ADR is expected? It's actually going to be explained by the mechanism of action of drug as well. That is going to be bradycardia. That is going to be what? Bradycardia. Okay, so we can explain this by the mechanism of action of the drug. Type B is very, very bizarre, unpredictable. You cannot actually explain this by the mechanism of action of the drug. For example, you have injected your patient penicillin, and this penicillin is actually going to cause anaphylactic reaction, or I would say hypersensitivity reaction. Now this hypersensitivity reaction, it could be ranging from a simple rash to fatality, as bad as death even can be seen, right? So penicillin induced hypersensitivity reaction, this could be a very good example that could be seen as a type B bizarre kind of ADR. It's very, very bizarre, highly unpredictable. You cannot say what can happen, what may not happen, right? So this was again quick summary of different kind of ADRs, A, B, C, D. Let me repeat. Are you all with me? Yes or no? Right? सोना नहीं है ना, कोशिश करते रहना है, right? जैसे किसी शायर ने बोला है ना कि मंजिल मिले ना मिले ये तो मुकद्दर की बात है। ऑल्दो हम मुकद्दर की बात ज़्यादा करते नहीं हैं, बट अगेन शायर तो कुछ भी बोलते हैं, मंजिल मिले ना मिले ये तो मुकद्दर की बात है, पर हम कोशिश भी ना करें ये तो बहुत गलत बात है ना। कोशिश करते रहिए, आप पुश करिए। ए ऑगमेंटेड, बी बिजार, सी क्रोनिक, डी इज द डिलेड, राइट? यू हैव टू कम आउट ऑफ दैट केज जो शुरुआत में मैंने बोला था ना कि आपको उस केज से बाहर निकालना है। That is going to take some effort, but believe me, that is going to happen. Next one, sumatriptan relieves acute migraine by acting as. So migraine ka what all question that could be asked, I'll be summarizing this topic. As I told you, 50 topics, 50 questions, 50 topics, that's it. Will be done in 1.5 hours. Sumatriptan relieves acute migraine by acting as a D2 antagonist. D2 antagonists are drugs like your haloperidol, droperidol. All these drugs are going to be D2 antagonists. They are typical antipsychotics. They have nothing to do with triptan, that is migraine. Okay, 5-HT1B by D antagonist, alpha 1 agonist. Alpha 1 agonist could be drug like your phenylephrine. We do not use phenylephrine in the management of migraine. So what is the correct answer for this one? Can you guys tell me? Yes, excellent. 5-HT1B by D agonist. 5-HT1B by D agonist. Now remember, this 5-HT1B by D agonist, a quick overview. If this is going to be the nerve ending of the cranial of 5, if this is going to be the cranial of 5 nerve ending, there is a peptide that is called CGRP. Whenever the CGRP is going to get released, they will be causing inflammation of the neurovascular bundles. On the presynaptic neuron, there is something called 5-HT1D, and a variant of the same is also present on the blood vessel, that is called 5-HT1B. It is present on the blood vessel. Whenever you are going to give 5-HT1B by D agonist, like for example, whenever you are going to give your triptan, right, these triptans are going to act as a autoreceptor activator. They will be activating 5-HT1D, and these are going to inhibit the release of the CGRP. So we are very happy with that. Actually, we are very happy that CGRP release will be inhibited, because if the CGRP is coming, they are going to cause a lot of trouble for the migraine patients, right? They are going to cause inflammation of the all the nerve ending, all the neurovascular bundles that is being innervated by cranial nerve 5. Plus this triptan, they are also going to cause what? Vasoconstriction. So because of this vasoconstriction that is going to be caused by triptans, remember, these triptans are actually going to be associated with increase in MI risk. Triptans can actually increase the MI risk, like sumatriptan, rizatriptan. All these are going to be triptans. Sumatriptan, rizatriptan, all these are actually triptan. They can actually increase the risk of MI. Triptans increasing the risk of MI. Point to be noted here, very, very important. Right now, there is a new drug that we have, which is also having a receptor on the presynaptic neuron, which also having action at the presynaptic neuron, because recently we found a receptor at the presynaptic neuron. This is called 5-HT1, 5-HTF, right? 5-HTF. All right, 5-HTF. Now this F do not give its innervation to the blood vessel. When it was asked Why don't you give your innervation to the blood vessel? It says, because I have a very unique 5st1F and I don't give my F to the blood vessel. I don't give an F, matlab F matlab 5st1F. I don't give an 5st1F to the blood vessel. है ना, आप समझदार हैं. So this 5st1F agonist that we know, right, it's actually going to be calling lasmiditan. The name of the drug is called lasmiditan. What is the advantage of lasmiditan? Lasmiditan example is that it does not give an F to the blood vessel. It does not give the F innervation to the blood vessel. And look at the names. Name says less MI देता है, right? Less MI देता है. They are associated with MI risk. They are not associated with any MI risk or precipitation of MI, right? ये less MI देता है. I hope all of you guys have got this one. Very very important. Less MI देता है question. All right. So here it is relieving migraine by giving us a 5:1B by D agonist. Remember that they are not any other antagonists or anything. Okay, plus they are increasing the MI risk. This is one of the recent PYQ. It has been asked in the recent examination as well, right? What is the drug of choice for prophylaxis of migraine? Drug of choice for prophylaxis of the migraine, it's going to be propranolol. It's going to be what? Propranolol. Another thing that you should know, right? That what are the anti-epileptic drugs that can be used in prophylaxis of the migraine? Which anti-epileptic drugs? So look at the question very very carefully. Which anti-epileptic drug is preferred in prophylaxis of the migraine? And first option will be propranolol. Please do not choose propranolol. Please do not choose propranolol. I am telling you the mindset of the examiner. I have heard the students making mistake because they just went prophylaxis and propranolol, right? So I'm telling you as a first hand experience, look at the question very very carefully. Anti-epileptic drug which is preferred as a prophylaxis of the migraine, there are two important drugs that we know. One is called valproate. Valproate, and other one is called a topi पहनने वाला very very famous drug that is called topiramate. Valproate and topiramate. Topi पहनने वाला topiramate, right? They are the anti-epileptic drugs that can be utilized for the prophylaxis of the migraine. There are so many other drugs that can be utilized because it's a upcoming examination. They may ask you which of the following is a oral CGRP antagonist. Oral CGRP antagonist, because CGRP is a post-synaptic neuronal, right, receptors. So you can even block these are the CGRP. So the CGRP receptor antagonist. This is going to be drugs like your Rimegepant, Ubrogepant, all the drug they are having Gepant. Remember, they are having the good news that they are having their advantage for the prophylaxis also, and can also be utilized in acute migraine. They can also be utilized in acute migraine. Okay. Since someone has mentioned this, as I said, the more you talk to me, the more you will learn. Someone mentioned about calcium channel blocker. I will quickly tell you. Prophylaxis calcium channel blocker में we can utilize verapamil and a very specific drug that is called your flunarizine. A very specific drug that is called your flunarizine, right? Flunarizine, right? Zavegepant intranasal, yes, right? Rimegepant, बिल्कुल. CGRP, Rimegepant. Flunarizine, it's also a specific calcium channel blocker, selectively having their action for the migraine, right? So I hope ये topic भी हमने cover कर लिया. I mean, this topic के around what are the questions that has been asked recently or that could be asked, we have covered. A newly developed antiviral drug is undergoing clinical trial to confirm its therapeutic efficacy. Confirming the efficacy, as soon as you hear the word confirmation of efficacy and comparison with the standard existing drug, it is going to be done in the phase 3 clinical trial. The other name of phase 3 clinical trial is called therapeutic confirmatory trial. The other name is called your therapeutic confirmatory trial, right? Confirmation हो रहा है, right? and you are not comparing in phase 2. In phase 2, patients are exposed for the first time. They are known as your exploratory trial, therapeutic exploratory trial. You are exploring this, right? And here patients are actually exposed for the first time. Exposed for the first time, right? We are not doing comparative analysis here, right? Phase 1, it is usually done on the normal healthy volunteers. It is usually done on the normal healthy volunteers. Phase 1, normal healthy volunteers, somewhere around 25 to 100 normal healthy volunteers. Phase 0, now my question to all of you guys, right? My question to all of you guys, phase 0 is done on animal or humans. Someone has asked about marketing. Yes, so that is going to be phase 4, that is known as your post marketing surveillance. It is actually called what? Post marketing surveillance. Once the drug is launched in the market, right? Once the drug is launched in the market, then this trial will be actually conducted, right? Once the drug is launched in the market, you'll have to keep an eye on the outcome of the drug as well. Then this is going to be phase 4. Therapeutic confirmatory trial is phase 3. Therapeutic exploratory trial is going to be your 2 normal healthy volunteers, that is going to be phase 1. Phase 0 is done on human or animals. Simple question. None of you have given the answer. Have you? Blinding, I'll tell you. Blinding, I'll tell you. First, answer me this one. Blinding, I'll tell you. Right? This is actually going to be an open label. Phase 4, open label. Phase 3 is going to be double blind crossover. Double blind crossover. After half of the study, you will be switching the therapy between the groups. So there is group 1, group 2, right? After half of the study, you are going to switch this group, right? So group 1 will be receiving the drug of group 2 now, and group 2 will be receiving the drug of group 1 now after half of the study. So we call it double blind crossover. That is a type of randomized study, randomized control trial. We call them randomized control trial. Okay. So many, all of you are saying animal. Very good, very good. है ना? Excellent. है ना? सब कितने पढ़े लिखे बच्चे हैं. Patients are exposed for the first time. Here there is going to be double blinding. Double blinding. Double blinding means even the patient and the researcher both are not available, not aware who is taking what kind of drug, and single blinding as well. So what is the meaning of double blinding, single blinding? See, in the early part of phase 2 mein, there will be single blinding, and late part of phase 2 mein double blinding. So basically here also blinding is done depending on whether we are talking early part of phase 2 or late part of phase 2, right? Phase 1 is also going to be an open label trial. Open label trial. To your surprise, I'll give you the answer to the question that I actually asked here. Phase 0, many of you are saying animal. No, it's not. Phase 0 is also done on the normal healthy volunteers. It is actually done on the normal healthy volunteers. और ये animal volunteer नहीं होते हैं. Animal will not come to you. सर जी, है ना, आओ, मुझे थोड़े पैसे दे दो और ये ट्रायल ले लो, मेरा ब्लड ले लो. नो, नॉर्मल हेल्दी वॉलंटियर्स, आई एम टॉकिंग अबाउट ह्यूमन वॉलंटियर्स. You will be informing them, right? You will be giving them all the details about your trial. Somewhere around, let's say, 5 to 15 normal healthy volunteers. 5 to 15 normal healthy volunteers, right, will be exposed with a very small dose of the drug. We call them micro dosing study, to study the pharmacokinetic property of the drug. Micro dosing study, where we are going to take normal dose, say we are going to take 1/100th of the normal dose. 1/100th of the normal dose, right? 1/100th of the normal dose. So as I said, that each topic, एक slide, one topic, done and dusted. What all information we have covered here, let me just quickly tell you. And let me tell you that phase 0, it is not done on animals. Boys and girls, since you have given the animal, I'll tell you, animal space, the trial that you have done on animals, you are going to do something called your pre-clinical trial. So even before phase 0, even before phase 0, you will be doing this one, right? Pre-clinical trial. Phase 0 is actually not a mandatory trial. It's a non-mandatory trial, but when you submit the report, definitely it holds the good weight on your confirmation, right? Phase 1, you are going to expose this slowly and slowly. The dose will be increased in normal healthy volunteers, and they are mainly assessed or done for assessing the safety of the drug. We are mainly going to assess, or we are mainly going to determine the safety. We are mainly going to determine what the safety in phase 1. Phase 2 may we are trying to explore, and we are trying to expose the patient now. Patient will be exposed with the therapeutic dose. And phase 3, it's the confirmatory trial. Phase 3 is going to be confirmatory trial. So these are the keywords in the question that you are going to see. Keywords in the question that you are going to see. Confirmation of the efficacy. Confirmatory trial. Confirmatory trial, what? Efficacy. Confirmation of the efficacy. All right. Then all the blinding, I told you, open label. Which is open label? 1 and 4 both are open label, right? Phase 2 and phase 3, there will be blinding done. Blinding will be done in phase 2 and phase 3. Blinding will be done in phase 2 and phase 3. Are we all good here? Are we all good here? Yes. So we have summarized the clinical trial as well. Next, the next question that I'm going to take is a 30-year-old man from Bihar. Okay, so when they ask the question from Bihar, it's either going to be leishmaniasis or it's going to be leprosy. So 30-year-old man from Bihar is diagnosed with the visceral leishmaniasis that we also call Kala Azar. What is the drug of choice for this condition? Okay, no, it's not the what is the drug of choice. It's not the drug of choice. Can you guys give me the answer to this question? Can you guys give me the answer to this question, please? Please give me the answer to this question. Come on. You have to be very, very careful now at this given point, right? June is about to enter and you will have 4 weeks for the examination. So you'll have to be very, very careful, especially from now for the next 4 weeks. क्या कंज्यूम कर रहे हैं, कितना कंज्यूम कर रहे हैं, एवरीथिंग शुड बी वेल कंट्रोल्ड, है ना. एक शायर ने वो अच्छी बात बोली है कि पाँव राइट हौले से रख ए कश्ती से उतरने वाले. फॉर माई नॉन हिंदी स्पीकिंग स्टूडेंट्स आई विल गिव यू द ट्रांसलेशन. राइट, पाँव हौले से रख ए कश्ती से उतरने वाले, आप उतरने वाले उस कश्ती से. राइट, कि जमी अक्सर किनारों से ही खिसका करती है. पाँव हौले से रख ए कश्ती से उतरने वाले, जमी हमेशा किनारों से ही खिसका करती है ना. तो जो कॉन्सेप्ट आपका गड़बड़ा जाता है, जो कॉन्फिडेंस जो टूट जाता है, वो यही समय है. तो यू हैव टू बी वेरी वेरी केयरफुल एट दिस पॉइंट ऑफ टाइम. Always stay in touch with your friends, with your senior, with your family, with your mentors, with your teacher, and keep right. Do not hesitate in taking help whenever you need. You will always find us whenever you are in need. Believe me. The correct answer that all of you are saying is A. All right. Yes, the key word here is oral drug of choice. बिल्कुल सही जवाब. Correct answer for this one is actually not liposomal amphotericin B. It's miltefosine. Miltefosine is the oral drug of choice. Oral drug of choice. Remember, it actually has orphan drug status. It actually also has orphan drug status. Orphan drug status for Kala Azar. It actually also has orphan drug status for the Kala Azar management. Liposomal amphotericin B, undoubtedly, it's the drug of choice for Kala Azar. Kala Azar ke liye it's considered as a drug of choice, right? We are going to utilize 10 milligram, 10 mg per kg IV. Single dose would also be enough. But if you want to give them right multiple doses, you need to give 5 mg per kg for 5 days. Single dose would be enough. But the problem with the liposomal amphotericin B, they are quite expensive drug. Remember, right? Liposomal, here lipid is added as a vehicle. The advantage that we are going to give, that liposomal amphotericin B, it will be having less nephrotoxic potential, right? Compared to the conventional amphotericin B, liposomal amphotericin B is going to be less nephrotoxic. They are going to be lesser nephrotoxic. Are we good here? Yes. We'll take the next question. Okay, ceftriaxone, remember guys, it's a third generation cephalosporin. It has no use here. Third generation cephalosporin. Metronidazole is one of the anti-amoebic drug. It's an anti-amoebic drug. It's an anti-amoebic drug. Next question. A patient on unfractionated heparin for deep vein thrombosis developed 50% drop in platelet. Look at the term, 50% drop On the 6th day of therapy, what is the immediate next step in the management? See, in the anticoagulants, two important things that I say. Whenever you are going to look at the anticoagulant, always expect this drama to happen. You expect this drama. Whenever you are going to look at the anticoagulants, you expect this drama. What is the drama that I am talking about? There are two anticoagulants. One is called warfarin. One is called what? Warfarin, and other one is called heparin. One is called warfarin, other one is called heparin. Warfarin, war. Remember, warfarin, they are actually associated with something called your purple toe syndrome. That is called paradoxical hypercoagulation. This is called paradoxical hypercoagulation, purple toe syndrome. And this is expected to happen, W for warfarin, it is expected to happen within 5 days of the therapy. Within 5 days of starting the therapy with the warfarin, right? So remember this. Always expect this drama in the anticoagulant. What is this drama? The paradoxical event. Warfarin is causing paradoxical hypercoagulation state, right? Because there is unopposed activity, right? This is mainly seen due to unopposed, right, clotting factor 2 activity, because clotting factor 2 will be the last factor to get affected. That will be taking around 5 days. Heparin, it's actually going to be associated with something that is known as your HIT syndrome. They are going to be associated with what? Something that is known as your HIT syndrome. What is HIT syndrome? That is called heparin induced thrombocytopenia. Heparin induced thrombocytopenia. There are two types actually. Type 2 is going to be the more problematic one. Heparin induced thrombocytopenia. Heparin induced thrombocytopenia, right? HIT syndrome type 2 is the more problematic one. Heparin induced thrombocytopenia, remember. And I always say that learn pharma in my style. There will be thrombocytosis also. Thrombocytopenia and thrombocytosis. This activated platelet will form thrombus. So this platelet plug formation, platelet clump will be formed here and there, and therefore in the peripheral blood smear you will find the platelet level lesser, right? So this is actually going to happen hafte bhar baad. This is within 5 days. This is happening around hafta, ya hafte bhar baad. Hafta is a week. So this is going to seen around a week after therapy, around a week after starting the heparin. Remember, so this is always going to happen. Now if something like this happens, what are you gonna do to prevent this purple toe syndrome or warfarin induced skin necrosis? You have to use the bridging therapy. You have to give the bridging therapy with low molecular weight heparin or even unfractionated heparin as well. Low molecular weight heparin. Here, if there is a heparin induced thrombocytopenic thrombocytosis episode, remember, for targeting this you have to use direct thrombin inhibitor. Guys, you will always expect this question. Your examiner is very fond of this topic and you will expect this question, believe me. Direct 2A inhibitor, drug like hirudine, lepirudine, bivalirudine, ergatrovan, malagatran, right? They are all going to be direct thrombin inhibitor. Now here, what is the immediate next step? Switching to enoxaparin, not going to help. Stop all the heparin and start ergatrovan. Yes, ergatrovan is also what? They are the direct thrombin antagonist. You don't need to give platelet transfusion because those activated platelet will also form platelet plug and they can cause more and more complication. Increase the heparin dose, no, that is not going to have. You have to use direct thrombin inhibitor. You are going to use direct thrombin inhibitor, right? Since we are using heparin and warfarin, as I told you that we have to cover one slide, one very important topic. I am going to tell you two important questions that was asked on these two topics. One is, if there is overdose, how will you monitor? If there is overdose, how are you going to monitor? That is going to be PT-INR. And the antidote is going to be vitamin K1. Antidote is going to vitamin K1. However, if bleeding is present, you can use, right, prothrombin complex concentrate, PCC, if the bleeding is present. If bleeding is present, prothrombin complex concentrate. Here, if there is overdose for heparin, then we are going to monitor by APTT, and antidote is called protamine sulfate. Although I'm pretty sure all my students are already aware about these, but there is no harm in revising this because your examiner is fond of asking this. Okay. The other name of vitamin K1 is called phytonadione. Remember, it's not only K, K1, phytonadione. Okay. Next question. Given image of transdermal patch is given here. All the following drugs are given by this route except which drug is not given by transdermal patch? I think, yeah, transdermal patch is which route? That is one question. Remember, it usually comes under systemic route, right? It usually comes under the systemic route. Transdermal is not intradermal route. Remember, intradermal is injectable. It's usually coming under systemic route. There is slow capillary absorption that is noted. Slow capillary absorption that is actually noted in this one. Among all of the given agent, remember nicotine transdermal patch available, testosterone is also available, scopolamine have seen is given. Penicillin, we don't have any transdermal patch. Penicillin is always and always injectable. They're always and always injectable. Penicillin. The oldest penicillin by the name of penicillin G, if you know, which was discovered by Sir Alexander Fleming, and that was the injectable agent. That was one very big limitation out of this. Are we all good here? Are we all on the same page? Hi everyone, are you able to revise this? So far we have covered around 15 topics. 15 topics we have covered so far. A patient present with the nausea and vomiting after consuming a large quantity of paracetamol tablet. Which of the following is specific antidote that works by replenishing the glutathione store? Now, this was the question that was also asked in January 2025. What was the question? The question was that antidote is given, how will they work? So this was the line, they replenish the glutathione store, right? So again, the correct answer for this question is going to be N-acetylcysteine. N-acetylcysteine, how do they work? They are actually going to replenish the glutathione store. They are going to replenish what? The glutathione store. Flumazenil is actually considered as the antidote for, it's actually considered as the antidote, flumazenil, antidote for benzodiazepines like diazepam and all, diazepam, etc. D-penicillamine is an antidote for copper, D-penicillamine. Deferoxamine is an antidote for iron. It's an antidote for iron. All right. So we have utilized this one. Yes, N-acetylcysteine has multiple uses. Since you have asked this one, Sabit Hassan, I'll just tell you. I always take this opportunity to clear that out and provide something extra whenever the student asks. See, N-acetylcysteine has multiple uses. N-acetylcysteine has multiple uses. One is called paracetamol overdose to replenish the glutathione store. Then chemo-induced nephrotoxicity, chemo or mainly cisplatin-induced, chemo or cisplatin-induced nephrotoxicity. So they have nephroprotective property also, and they are also utilized as a mucolytics. They are also utilized as mucolytics. So N-acetylcysteine is one of the drugs that is having multiple uses, and the use is also very, very simple. PCM, paracetamol, chemo or cisplatin-induced nephrotoxicity prevention, and other one is called as a mucolytic as well, right? INICT question was there, that what was the toxic intermediate metabolite? Paracetamol, toxic intermediate metabolite. The paracetamol toxic intermediate metabolite is called NAPQI. They are the one, N-acetyl P-benzoquinone-imine, N-acetyl P-benzoquinone-imine, right? They needs to be reduced by glutathione. They need to be reduced by glutathione. Hi everyone, are we all good? We are taking you to the next one. A patient on long-term rifampicin therapy developed reduced therapeutic response to oral contraceptive. All-time favorite question of the examiner. And mind it. General pharma, if you're asking me, sir, which is one topic that I should read, I always say read the drug interaction. Like here, inducer will induce, causing failure. Inducer will induce, it will cause failure. Inhibitor will inhibit and it will cause toxicity, right? Too much inhibition leads to toxicity. If you have ever attended the class, I always tell you a very beautiful story of how in a relationship of a boy and girl, how when they get too much induced, they get failure grade maybe in the class test that I conduct, right? So failure grade because you're getting induced, है ना? Because you're induced every time you're trying to study, someone is inducing you, है ना? Inducing, I said, not S word, I said inducing. Induce failure. If you're getting inhibited too much, someone is denying you too much, there will be too much toxicity that will fill inside you, right? So cutting the long story short, right, inducing will cause treatment failure. I'm just writing here as well so that you can just pick it in the examination. And too much inhibiting will cause toxicity. It will cause toxicity, risk will actually be increased. Rifampicin, remember guys, it's one of the first line anti-tubercular drug, and rifampicin is one of the very, very potent enzyme inducer. They do not compete with the estrogen, rather enzyme induction of the hepatic microsomal enzyme. They are the very, very potent enzyme inducer. Too much inducer, it will cause treatment failure. Like here, oral contraceptive pill will not be working. Now this is called contraceptive failure. Here what we are getting is contraceptive failure. Let me add one more pearl to your preparation. We have discussed A, B, C, D kind of ADR. A, augmented, B, bizarre, C, chronic, D, delayed, E, end of treatment, that is the withdrawal symptom. And here, because there is a treatment failure that is happening, this is an example of type F ADR. F is failure of therapy. F is failure of therapy, right? F is failure of therapy. Now, I'll take this opportunity very quickly to tell you two more important points about rifampicin. Point to be noted, number one, that drug like rifampicin, it is one of the first line ATT. Drug like rifampicin, it's going to be first line ATT, anti-tubercular drug, first line ATT therapy. Second point, one point that I told you, there is enzyme inducer, that I'm no longer I'm going to repeat that. And another point that you should know is the important mechanism of action. R stands for rifampicin, R for RNA. So they are one of the RNA polymerase inhibitor which is dependent on the DNA. RNA polymerase inhibitor which is dependent on the DNA. So they are going to be DNA dependent RNA polymerase inhibitor, and because of this they are having sidal effect. DNA dependent RNA polymerase inhibitor, and because of this they are actually having sidal effect, sidal action, right? Tuberculocidal property is going to be seen, and important side effect is going to be red, orange urine or body secretion, or even lens staining, tear, lens staining, and they can even lead to flu-like symptom, hepatotoxicity. Again, these are the high-yield topics from this slide that I want you to take. These are the bare minimum information that I want you to remember from these areas, right? So rifampicin, it's one of the drug that is a very, very potent enzyme inducer. It's one of the RNA polymerase inhibitor which is dependent on the DNA. So full name is called DNA dependent RNA polymerase inhibitor. Cutting the long story short, revising all over again, too much induction, don't get induced. If you're attending my class, especially don't get induced. If you are getting message, अगर उनका ख्याल आए तो उनके ख्याल को दूर रखिए. If you are getting messages, calls, where are you, come home, there is a coffee waiting, right? Induce नहीं होना है, सख्त लौंडे बनिए. कब समझ में आएगा आपको, है ना? You have to be very, very strong mentally. सख्ती दिमाग की जरूरी है, जो मैं बोल रहा हूं आप समझ रहे हैं, राइट? सख्ती यहाँ की सख्ती जरूरी है, बिकॉज इफ यू गेट टू मच इंड्यूस्ड, टू मच इंडक्शन could lead to, right, failure in the grand test that is going to be conducted. Too much inhibition will lead to toxicity, and do not get too much inhibited, it will lead to toxicity, right? You'll be able to crack the question if it is going to be asked. Which of the following beta blocker possesses intrinsic sympathomimetic activity? Now this intrinsic sympathomimetic, that means they are not completely blocking the beta receptor, right? So at some beta they are having blocking property, at some beta they are having agonistic property as well. So which of the following beta blocker possesses intrinsic sympathomimetic activity? So the beta blocker that is possessing this one, right, that is going to be labetalol. There are so many actually: labetalol, acebutolol, but I want you to remember only three: labetalol, acebutolol, and other one is called pindolol. These are the beta blocker that actually have two very important property. One is called intrinsic sympathomimetic activity, and other one is called local anesthetic property. These both properties noted with these. Both properties noted with this, right? Both property is noted with this. All right. Intrinsic sympathomimetic activity and local anesthetic property. Both property is noted with these. There are 7, 8 in the intrinsic sympathomimetic activity, and LAP is called local anesthetic property because of the additional sodium channel blocking property. Local anesthetic property is also noted with this. So these three have all these, both the properties. Correct answer for this one will be pindolol. 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 All right. Atenolol, it's going to be cardioselective beta blocker. Metoprolol is also another cardioselective beta blocker. One property that you should know, among all the cardioselective beta blockers, they are the most commonly utilized cardioselective beta blockers. They are the most commonly utilized cardioselective beta blocker among the beta blocker that you should know, right? Most commonly utilized cardioselective beta blocker. नीता मोटवानी, yes, thank you very much. And आप लोग का प्यार है जो इस बुक को पिछले more than a decade the book is helping the student, and I hope that in upcoming examination also it should help you out. As long as you're through with the previous year topics, previous year question are not repeated, topics are usually repeated. So one such session is being conducted here, right? I hope we are all on the same page. Moving on to the next one. A patient receiving gentamicin develops hearing loss. Which structure is primarily affected? What is gentamicin? What is gentamicin? Remember, it's the aminoglycosides. What are the important point I can squeeze down here? That is what I am doing. If you are observing the pattern, aminoglycoside, this is actually going to be a what? Protein synthesis inhibitor. Usually protein synthesis inhibitor, we say majority of them are static, but this is one protein synthesis inhibitor which is having sidal property. These protein synthesis inhibitor, they are mainly acting at the 30S ribosomal subunit. They are binding at the 30S ribosomal subunit and causing misreading of the mRNA sequence. Misreading of the mRNA sequence. So if there is a misreading of the mRNA sequence, this will actually lead to formation of abnormal protein, and that abnormal protein is not compatible with the life of the bacteria. It's not compatible with the life of the bacteria. It is one of the bactericidal drug, aminoglycosides. Remember, it's a broad spectrum antibiotic, usually utilized as empirical therapy. Usually utilizes the empirical therapy, and they have a lot of other use like anti-tubercular therapy, respiratory infection, multiple condition we can utilize. But remember, the examiner do not ask that. Examiner asks where it is not utilized, no use. So remember, it is not effective. It is not effective for. It is actually not effective for anaerobes. It is not effective for anaerobes. Aminoglycoside is not effective for anaerobes. Now, are they causing hearing loss? Yes, of course. So they will be causing, they are actually associated with ototoxicity. Yes. Nephrotoxicity, that is also correct. Ototoxicity, nephrotoxicity, and they can even cause neuromuscular blockade. Neuromuscular blockade. Because of that, I mean, they can even be problematic if you are going to use them in myasthenia gravis patient as well. Now, look at this. They are asking which structure is primarily affected when he is having hearing loss. Okay, so hearing loss, that means there is a problem with the sensory organ of the hearing. Which is the sensory organ of hearing? If you know, organ of corti happens to be the sensory organ of hearing. Sensory organ of hearing. Correct answer is going to be option B. Stria vascularis, it's going to be the sensory organ of angular motion. They are the sensory organ for angular motion. You must have read this in your anatomy and in your ENT as well. Stria vascularis, है ना? Stria vascularis. All right. Shubham Chandel is asking which edition. That is going to be 10th edition. They do not affect tympanic membrane or eustachian tube. No? They are not affecting that, right? The correct answer for this one is going to be organ of corti, that is causing your hearing problem. If there is the abnormality with the balancing, then stria vascularis would be affected. Which of the following drug is contraindicated in patient with myasthenia gravis? Again, I think again, same topic ka question. Myasthenia gravis. Which drug is contraindicated in myasthenia gravis? So the answer to this question is again going to be gentamicin. Now let me just quickly squeeze down some important information. Adrophonium is mainly utilized for screening of myasthenia gravis or to differentiate between myasthenia gravis and cholinergic crisis, because a patient of cholinergic crisis may also present with the weakness, ptosis, diplopia, same symptom. All right. Pidostigmine and neostigmine, they are going to be utilized in the treatment of myasthenia gravis, right? They are not avoided. They are utilized in the treatment of myasthenia gravis, remember? Along with the atropine will also be added in this case scenario, right? Gentamicin is the aminoglycosides, and aminoglycoside, they are having neuromuscular blocking property. In a myasthenia gravis, there is already going to be auto antibody against the postsynaptic acetylcholine receptor, right? There is already going to be the auto antibody against postsynaptic acetylcholine receptor, autoantibody against postsynaptic acetylcholine receptor. Okay, so there is already autoantibody, and if you are going to give an antibiotic that is also having NM blocking property, they can cause worsening of the myasthenia gravis. They can worsen the myasthenia gravis, and that is why they are contraindicated in myasthenia gravis patient. Next one. Which of the following anti-arrhythmic drugs shorten the action potential duration? Now, I am going to take this opportunity very quickly to squeeze down the anti-arrhythmic drug का classification कैसे याद करना है and how to solve all the graph, because graph वाला question is expected. Which anti-arrhythmic drug shortens the action potential duration? Now, action potential duration, if you are going to see, action potential duration is having multiple phases, right? This is going to be phase 0, we have phase 0, phase 1, phase 2, 3 and phase 4. So this is phase 0, phase 1, phase 2, phase 3, phase 4. Phase 0 is mainly because of the sodium that is going inside, sodium influx. Phase 1 is mainly going to be potassium efflux. Phase 2, due to two reasons. One is potassium continues to go out, and whatever positive charge that we are losing, it is maintained by the calcium. And phase 3, there is a continuous potassium efflux. Phase 4 is going to be the resting membrane potential, that is minus 90 millivolt. All right. Now try to understand this, the different phases that we have, like phase 0, 1, 2, 3, right? What was the reason for phase 3? That was potassium efflux. What was the reason for phase 3? That is going to be potassium efflux. Now, at any given time, if I am going to give my patient something called your sodium channel blocker, what's going to happen? I want you to put your eyes on the screen, please, and tell me, if you're going to block the sodium channel, what will happen? Let's say this is one of the action potential duration. If you are going to block the sodium channel, what kind of outcome you are expecting? What kind of outcome you are expecting if you're going to block the sodium channel blocker? Can you tell me? What kind of outcome can we expect if we are going to block the sodium channel? What kind of outcome can we expect? See, when we are blocking the sodium channel, upon blocking the sodium channel, I will see there is going to decrease in the slope of depolarization. The slope of depolarization is going to be decreased. It will take more time to get depolarized. Everything else is going to be normal. This is mainly going to be seen if you are going to give your patient something called a sodium channel blocker. Let me just compare this outcome with the other, like let's say potassium channel blocker. Then what will happen? When you give potassium channel blocker, you are not going to see any change. You are not going to see a change in the slope of depolarization. It will be normal as it is. Slope of depolarization will be normal as it is. But because of the potassium channel blockade, it will be very slow efflux of the potassium. Potassium will be going very slowly, and therefore it will take more time to repolarize. Any potassium channel blocker, therefore, they have the potential that they can increase this action potential duration. And on the ECG, they are the drug that is causing QT interval prolongation, right? Because they have one ventricular depolarization also and repolarization also. right? At any given point, if I'm going to give a drug that is called, let's say, potassium opener, then what's going to happen? See, when you give potassium channel opener, the potassium would be rapidly going out. Now the potassium would be rapidly going out. Because of the rapid efflux of the potassium, the repolarization will be very, very fast. The repolarization will be very, very fast, and they are actually going to decrease this action potential duration. They are actually going to decrease the action potential duration, right? Decrease the action potential duration. Now, first and foremost, which of the following drug shortens the action potential duration? Which type of drug is quinidine? Quinidine, remember guys, it's class 1A, procainamide, class 1A, lignocaine, class 1B, amiodarone is going to be class 3. Amiodarone is going to be class 3, which is a purely potassium channel blocker. Class 1B, they are going to be sodium blocker. All the class 1 is sodium blocker with potassium opener. 1A is going to be sodium blocker with potassium blocker. 1C has no action on the potassium. They are mainly the sodium channel blocker. Now I want you to see this one and tell me that in which type of drug there will be shortening of the action potential duration. On the basis of the information that I just gave you, on the basis of the information that I just gave you, in which type of drug there will be high risk of, in which type of drug there will be high risk of shortening of the action potential duration? Who can tell me? इनमें से किसका एक्शन पोटेंशियल ड्यूरेशन कम होगा? इन विच टाइप ऑफ ड्रग विल हैव शॉर्टर एक्शन पोटेंशियल ड्यूरेशन? वेरी गुड, दैट इज पोटेशियम चैनल ओपनर, दैट इज गोइंग टू बी क्लास 1C, right? 1C. This can actually cause QT prolongation, and even class 3 also can cause QT prolongation. When you are going to look at the classification, something called your Vaughan-Williams classification, Vaughan-Williams classification of anti-arrhythmic drug, I'll tell you a very simple way and you'll remember it immediately in just 1 minute. Vaughan-Williams classification, according to this, there are multiple class, that is 1, 2, 3, 4, and miscellaneous group or other. So there is going to be sodium blocker. 1 will be sodium blocker, 2 will be beta blocker, 3 will be potassium blocker, 4 will be calcium blocker, and this is going to be all others or the miscellaneous group of drug. All others are miscellaneous group of drug. I always say that when you're going to remember this, you remember it for a long time, and you remember like this, that soda blocks potassium channel. I want you to repeat with me. Soda blocks potassium channel. Repeat with me. Soda blocks potassium channel. Soda blocks potassium channel. Now this soda drug, soda class 1A sodium, they are further subdivided into 1A, 1B and 1C drug. 1A, 1B, 1C. 1A, they have sodium blocking property with potassium blocking property as well. 1B, they are brave group of people, they kick the potassium out, bahar karenge, B for bahar, so potassium would actually be open, potassium channel opening property. And 1C is having only and only sodium channel blocking property. They have no action on the potassium. They have no action on the potassium. I hope all of you guys are with me. Hello. 1A, 1B, 1C. A very simple example of 1A is going to be quinidine, and there is going to be procainamide, quinidine, procainamide, and other one is called your disopyramide. So they are going to be the A grade people. A grade people in a kingdom of arrhythmia, if you see, if it is A grade people in a kingdom of arrhythmia, these A grade people are going to be a queen, a prince, and a dasi. A grade people are going to be a queen, a prince, and a dasi. A grade people are going to be a queen, a prince, a dasi. Repeat with me. A grade people are queen, prince, and dasi. The B grade people are very brave group of people, and this brave group of people, B for Bahar, brave group of people, they are so brave that they always talk about themselves and they say, we are so brave that they all like to phone me. Any arrhythmia, they all like to phone me. And this B group of drugs are talking among themselves and they are looking and mocking at other drugs. They like to phone me. Like to phone me is going to be lidocaine, tocainide, phenytoin, and anti-epileptic drug having anti-arrhythmic property, and maxilitine. Repeat with me, please. Maxilitine, right? So we have like to phone me, and C grade, this is B is the brave, like Senapati type. They used to say they like to phone me. Any problem in the kingdom, I'm so brave. They all like to phone me. Lidocaine, tocainide, phenytoin, maxilidine. And then there comes the 1C. 1C group of drug. They are very, very C kind of. C kind of matlab, how to say this live. C kind of means very rare kind of, है ना? बाकी आप खुद समझदार हो, I understand. The C grade people in the kingdom, they are doing all the C grade work in the kingdom. Like for example, floor per mopping, etc. Floor per mopping, etc. is going to be flecainide, propafenone, moricizine, nkainide. Repeat with me, and you are going to remember it once and for all. Abhi yaad ho jayega. They are C grade people and doing C grade wala work, C grade wala job of the society, of the kingdom. There is a kingdom of arrhythmia. All the C grade wala job is given to them. They are floor per mopping, etc. Flecainide, propafenone, moricizine, nkainide. Who are the A grade? Are you all with me? Wherever you are, please repeat with me. Please repeat with me. Anna, A grade. Who are the A grade in the kingdom? A queen, a prince, a dasi. They are the A grade people. They are staying in A grade and enjoying all the A grade luxuries of a life. Now you might be wondering, sir, what kind of dasi are you talking about? Dasi is helping hand servant, but I'm talking about a kingdom. Do you read the history or not? Nowadays, so you don't. But have you read the history in past or not? Have you not read? A king used to have 100 dasis, and he used to make the big palace for them. है ना? They used to call them haram. है ना? And those dasis are imported from Iran, from Iraq. And at that point of time, also, those kings were, very fond of getting the dasis from Russia. है ना? और वो क्रेज इंडियंस का अभी तक बरकरार है, right? So queen, prince, dasi, right? So there's going to be quinidine, procainamide, disopyramide. So I'm talking about the dasi of the kingdom era, the Mughals era and the kings era, right? B grade people, the brave group of people, like to phone me lidocaine, tocainide, phenytoin, maxilidine, and 1C, floor per mopping, etc. B is the beta blocker that is going to be all ending with the LOL drug like atenolol, metoprolol, all the LOL drug that we know. A very important drug here from class 3 is going to be amiodarone. Class 4 is going to be verapamil diltiazem, right? So this was again a quick summary of Vaughan-Williams classification. A very, very important. Soda blocks potassium channel. क्या आप रिपीट कर रहे हैं? जहां कहीं भी हैं एकदम खुल के बोलिए, है ना? अगर लाइब्रेरी में है तो थोड़ा धीमे बोलिए, है ना? लेकिन घर पे हैं या कहीं ऐसी जगह है जहां शाउट कर सकते हैं, शाउट करके बोलिए. द मोर यू लर्न, द मोर यू अर्न इन टर्म्स ऑफ नॉलेज. Next question, next topic. A patient with hypertension and BPH, benign prostatic hypertrophy, started on drug that improves the urinary flow. So what all topic that has been what all question has been asked on BPH, I will be summarizing in this one, right? All right. Is started on a drug that improves the urinary flow while lowering the blood pressure. Which drug is most appropriate? Okay. So for this one, it is actually going to be prazosin. Abdul Rahman is asking, yes, there will be a session on the YouTube. You will just be notified, not on this official channel of PW, but there will be class of that. I'll help you in revising that. Don't worry about that. And just keep following on the social media platform. You will be notified about that. Abhi ke liye, we have excellent ENT faculty, and believe me, he will rock your life in ENT. So just listen to him when he comes live, whenever he comes. Right now, I am going to rock your life in pharmacology. Let's focus on pharmacology. And जैसा कि मैंने बोला था, 1.5 to 2 hour. If I am not wrong, 1.5 hour हो गया. Oh my God. I did not see the watch. We are left with half an hour. Don't worry. I will cover that in half an hour. And good. I have a very good speed. Drug of choice for BPH in a patient with the hypertension is this. Next question, if the examiner is going to ask you, what is the drug of choice for only benign prostatic hypertrophy? The answer to this question is going to be drugs like your tamsulosin, silodosin, the good news about tamsulosin and silodosin, that this class of drug is actually going to be, alpha 1A blocker. The advantage is that they do not cause postural hypotension. They do not cause postural hypotension. This is one of the PYQ. If you are solving the PYQ book, you must have come across this question. The advantage of giving tamsulosin over prazosin is that they do not cause postural hypotension. They do not cause postural hypotension. Remember this one. Okay. What is the other drug? Other drug for BPH, other drug for benign prostatic hypertrophy? That is going to be drugs like your finasteride. What is the mechanism of action? That is going to be a 5-alpha reductase inhibitor. 5-alpha reductase inhibitor. This other drug for BPH, it can also decrease the prostatic volume. It also decreases the prostatic volume or size of the prostate. It also decreases the volume or size of the prostate, right? So about BPH, all the important questions that I have summarized here. Propranolol is a non-selective beta blocker. Clonidine is going to be alpha 2 agonist. They are actually associated with, as rightly mentioned by Nisar, they are actually associated with rebound hypertension. Yes, rebound hypertension and constipation. Hydrochlorothiazide has, it's a diuretic. Hydrochlorothiazide is diuretic that is working at the early part of DCT by blocking NaCl cotransporter. So this is also one of the important question that has been asked in the PYQ, right? So again, this slide is also been sorted. Alright, so देखिए ये है आपको repeat करने का तरीका. When you see the question, you should know the answer of the question and other options, because next time there will be question on other options as well. ठीक है? Which of the following diuretics act by inhibiting NaK2Cl? Co-transporter at the thick ascending limb of loop of Henle. NaK2Cl at the thick ascending limb of loop of Henle, that is going to be actually talking about loop diuretics. It's actually talking about what? Loop diuretics. Remember, hydrochlorothiazide, they are blocking what? NaCl co-transporter. I just told you at the early part of DCT. Spironolactone, they are going to be aldosterone receptor blocker. They are also given the name as the potassium sparing diuretics. Spironolactone, eplerenone. Remember a very, very important question, that this is the only diuretic. Which is acting at the interstitial end. All other diuretic work towards the luminal end, but this is the only diuretic that is working towards the interstitial end, that is spironolactone, eplerenone. They are the aldosterone receptor blocker. Acetazolamide, dorzolamide, they are known as carbonic anhydrase inhibitor. Right? They are known as carbonic anhydrase inhibitor. All right. Since someone mentioned about autotoxicity, let me just quickly tell you that the two important problems that you should know. One, there are a lot of problems. One important problem is autotoxicity. Yes. Other problem is that they cause, look at the term that I'm writing, look at the line that I'm writing, they cause hypercalciuria. क्या आपने समझा मैंने क्या लिखा? Have you heard, have you seen, did you notice this? Hypercalciuria. Excess calcium will be lost in the urine, because we always say in class, loop causes loss of calcium, and because of that the serum calcium level will be low. Right? Because of this the serum calcium level will be low. A very, very important point because of this, which I would like to highlight, that loop diuretics are going to be contraindicated in two very, very important conditions. LD is loop diuretics. They are contraindicated in patient with the history of renal stone history, and if there is a history of hypocalcemia history. Loop diuretics are going to be contraindicated. In fact, there in 2025 only this question was asked, which diuretic is preferred in a patient with a history of renal stone. Remember, it is the thiazide diuretics. That are actually preferred in renal stone. It is a thiazide diuretic that are going to be preferred in renal stone or hypocalcemic patients, or patient with history of hypocalcemia. Okay. Crystal Medicos has asked a very big doubt. Sir, can we give NSAID with loop diuretics or antibiotic? They decrease the action of this because the inhibition of probenecid. देखिए NSAIDs are always going to be inhibitor of the prostaglandins, and if the prostaglandins are inhibited, the blood flow to the kidney will be compromised. That will be blunting the diuretic effect. So should you use NSAID? Ideally, we should avoid. What kind of interaction NSAID can cause? They will blunt the diuretic effect, right? How they will blunt the diuretic effect? By decreasing the prostaglandin level, because NSAIDs act by inhibiting cyclooxygenase enzyme, and COX enzyme is the rate limiting enzyme for prostaglandin synthesis. Okay. All right. A patient receiving isoniazid develops peripheral neuropathy. Which vitamin supplementation? Another question that has been asked. So the correct answer for this is going to be vitamin B6. Remember, we Indian population are known as your slow acetylator. Isoniazid is a drug that is going to be metabolized by acetylation. Slow acetylators. Okay. Isoniazid is a drug. It is mainly going to do two things. One is it is going to promote vitamin B6 का excretion renally. They are promoting renal excretion of vitamin B6. Another thing, they are going to inhibit pyridoxine activation. They are going to inhibit the pyridoxine activation to pyridoxal phosphate. Pyridoxal phosphate, boys and girls, is the active form of pyridoxine. Pyridoxal phosphate is the active form of pyridoxine. They are going to inhibit the pyridoxine activation to pyridoxal phosphate, and because of this, isoniazid can always increase the risk of peripheral neuropathy. Okay, so vitamin B6 is added. Now, what is the other important topic that I can add here about isoniazid that was asked in just very recent 2025 January में this question was asked. You can check it out in the PYQ section. The question was this, that which drug develop resistance due to CAT-G gene mutation? So remember, isoniazid, it's actually get activated. The activation of isoniazid is actually by the enzyme that is called your catalase peroxidase. Catalase peroxidase is utmost important for the activation of isoniazid, because catalase peroxidase is an enzyme. This catalase peroxidase, which is actually an enzyme, they are activating isoniazid. This enzyme definitely is being coded by some gene. So there is one gene by the name of CAT-G gene. CAT-G gene encodes this catalase peroxidase. Therefore, if there is any mutation in the CAT-G gene, there will be resistance with the isoniazid. So which gene mutation will lead to isoniazid resistance? That is commonly CAT-G gene, Katrina G wala gene. I always say that make sure Katrina G don't get mad. If Katrina G will get mad, the ice will not melt, right? If you want the ice to melt to form active one, if you want the ice to melt and form the active one, make sure Katrina G is working normally and at its optimal speed. Katrina G, if she get mad, what will not melt? Ice will not melt, na? So Katrina G, ice. Which of the following insulin preparation has the longest duration of action? Among the given one, regular, right? They are also among the shorter acting now. Lispro, NPH intermediate acting में आते हैं. This is glargine. Glargine is longer acting one. Glargine is one of the larger acting one. Glargine, they are actually going to be large acting. Glargine, look at the name, they are actually the large acting, right? Then there is another one by the name of D-gludec. They are lasting for up to 42 hours. The large acting one lasting for nearly 24 hours, right? Lasting for nearly 24 hours. All right. D-gludec. More delayed action, right? Glargine, large acting, right? Up to 24 hours, right? So longest acting is going to be your glargine, D-gludec, and then there is one more that is called detemir. This is also delayed response. So look at this. Detemir, they are also the long acting. Another very important question that I can squeeze down in this topic is all the long acting insulin, boys and girls, all the long acting insulin that we know, they are given the name as a peakless insulin. They are given the name as a peakless insulin. They do not form a peak. Unlike the shorter acting that will immediately form a peak, intermediate acting will also form a peak and will come down. But when you are going to look at the longer acting, they do not form a peak, right? They are not going to form a peak. So these are known as peakless insulin. This is called long acting. This is the short one, and this is called the intermediate acting one, right? So they do not form a peak. Who do not form the peak? That is going to be the longer acting. All right. Next one. Which of the following drug is a selective serotonin reuptake inhibitor? Again, one topic, one slide. We give 0.5 unit per kg. So if it is, let's say, 60 kg male, 0.5 unit per kg. So if there is, let's say, example, there is going to be 60 kg patient, then out of 60 kg, 50% you have to give as a basal insulin and 50%, right, in divided doses, right, around meal. So if it is 60, so that will be totally 30 units. So 50% basal insulin, that means it will be given in the night time for the control of the morning sugar. That will be around 15 unit the person will take, and here it will be 5, 5, 5. Okay, Dr. Crystal Medico. I hope it is also sorted. Okay. In emergency, we can give as high as 1 unit per kg. Okay, like diabetic ketoacidosis. Which of the following is a SSRI, selective serotonin reuptake inhibitor? Selective serotonin reuptake inhibitor, I always say that they are going to be FFPS, that is going to be citalopram, escitalopram, fluoxetine, fluoxamine, paroxetine, and other one is called your sertraline. This is going to be sertraline, CEFFPS, chef drug. They are very chef drug. Among the given one, which is a SSRI, so I think fluoxetine, a very longer acting one. They have very long T half life, because fluoxetine, it is metabolized to give rise to norfluoxetine. According to Katzen, norfluoxetine, it lasts for nearly 180 hours. They're very long acting. Amitriptyline, which group of drug? It's one of the amitriptyline is which group of drug? Remember, amitriptyline, it's one of the TCA, that is going to be tricyclic antidepressant. Imipramine is also one of the TCA, tricyclic antidepressant. Venlafaxine is going to be SNRI, serotonin noradrenaline reuptake inhibitor. Venlafaxine is going to be SNRI, serotonin noradrenaline reuptake inhibitor. Vanilla and a vanilla duals and a two neurotransmitter है ना. So after the class today you buy vanilla है ना, कभी अपने लिए या कभी उनके लिए, आपका प्यार दुगना हो जाएगा, 2 न्यूरोट्रांसमीटर बढ़ जाएंगे, सेरोटोनिन या नॉरएड्रेनालिन. वनीला खरीद के देखिएगा, है ना. Which of the following anti-epileptic drug act primarily by blocking T-type calcium channel? See, T-type calcium channel is blocked by many drugs. One of the very important drug is ethosuximide. Primarily, it's saying primarily. Valproate का primary mechanism of action is voltage gated sodium channel blocker, but it can also be a T-type calcium channel blocker. It can also be one of the GABA transaminase inhibitor and succinic semi-aldehyde dehydrogenase inhibitor. Can you see valproate is having multiple mechanisms of action, but ethosuximide का primary mechanism is going to be T-type calcium channel blocker. Because I am discussing ethosuximide here, let me just take this opportunity very quickly and squeeze down important PYQs of this one. They are the drug of choice in absence seizure. Please remember, my dear student, examiner will never use the term absence seizure for you. They'll give you a school-going child with poor scholastic performance, or poor grades, right? teacher will actually complain, आपके बच्चे का ध्यान नहीं रहता है, your child is not paying attention in the class. When I call here, he'll go there, right? Or he doesn't listen, he do not move. Sometimes he moves, sometimes he stops, right? Upon EEG, there is a specific finding of 3 Hz per second spike and wave pattern. This is mainly discussed in the pediatrics as well. EEG pattern will be asked, and they will be asking what is the important drug of choice. That is going to be ethosuximide being the drug of choice. The drug of choice is going to be your ethosuximide. Can we use Valproate? Yes, Valproate can also be used in, it can be used also in absence seizure, all cases, but especially atypical absence seizure. Atypical cases, atypical absence seizure. Okay. Phenytoin, carbamazepine, these both drugs are mainly voltage-gated sodium channel blocker. Moving on to the next one. A patient with Parkinson's disease started on levodopa. Why is carbidopa co-administered? So levodopa is not given alone. Levodopa, when you give alone, this levodopa in the periphery, it will be converted to dopamine, because in the periphery we have an enzyme that is called dopa decarboxylase. So dopa decarboxylase, it will cause breakdown of this levodopa into dopamine, and this dopamine, it is going to work, on the dopamine receptor, and they will cause lots and lots of peripheral side effects. They are going to cause lots and lots of peripheral side effect. They will be causing lots and lots of peripheral side effect. So we have to make sure that we are inhibiting this peripheral dopa decarboxylase. This is actually peripheral dopa decarboxylase, and this peripheral dopa decarboxylase is called a drug by the name of carbidopa, and other one is called your benserazide. Carbidopa, and other one is called your benserazide. Carbidopa is the one that is commonly utilized. In fact, they are available in the fixed dose combination with the levodopa. So they are peripheral dopa decarboxylase inhibitor. Let's read the option. To increase the dopamine sensitivity, no. To inhibit the peripheral decarboxylation of levodopa, that's correct. To reduce the central symptom, to increase the levodopa, no. The correct answer is B. I think all of you guys have got this one, right? Excellent. I want you guys, as soon as you see the question, immediately start giving your answers in the comment section, right? Which of the following drug is used as a mood stabilizer in bipolar disorder? We are about to finish. Which of the following drug is used as a mood stabilizer in bipolar disorder? Mood stabilizer in bipolar disorder is going to be your lithium. Lithium is one of the IMPase inhibitor, right? It's IMPase inhibitor. They are utilized for mania as well, and they can also be utilized in bipolar disorder as a mood stabilizer in bipolar disorder as well. But if the examiner is going to ask you drug of choice for rapid cycler in bipolar disorder, rapid cycler is anyone who is having more than or equal to 4 cycle per year, right? More than 4 cycle per year. The answer to this question is going to be Valproate. The answer to this question is going to be Valproate. Rapid cycler ka correct answer is going to be Valproate. I hope it is making sense to all of you. Yes. Are we all good here? Sertraline is going to be an SSRI, not a mood stabilizer. They are antidepressant actually. They are antidepressant. I'll rule out other options as well. Haloperidol, they are going to be D2 blocker. Typical antipsychotic. Diazepam is one of the benzodiazepines. That is one of the GABA facilitator. They are one of the GABA facilitator, right? Are we all good here? आपके responses थोड़े slow हो गए हैं. अब वो बात नहीं रही जो आप शुरुआत में थे. शुरुआत में तो आप बड़े एनर्जेटिक थे, अभी आप शांत हो गए हैं, है ना? चलिए. Which antihypertensive lowers the blood pressure by opening the potassium channel in vascular smooth muscle? Lowering the blood pressure by opening the potassium. So simply they are asking which of the following is a potassium channel opener. The correct answer is going to be hydralazine. Although hydralazine exact mechanism of action is going to be questionable, they have multiple mechanism. One of the mechanism is going to be potassium channel opener, and they have some calcium sensitive potassium channel opener, which are calcium sensitive. Plus they have said that there is possible other mechanism of action as well. But for the usage in hypertension, this is the one acceptable mechanism that we have, right? Minoxidil, it's actually topical. Yeah, they are also potassium opener. Right? Topical, it's actually utilized for androgenic alopecia. It is usually utilized for androgenic alopecia. Enalapril, it's one of the AC inhibitor. Captopril, lisinopril, enalapril. Verapamil is one of the non-DHPs. Non-DHP, they are the calcium channel blocker. Non-DHP, they are the calcium channel blocker. So they inhibit the calcium entry into the nodal tissue, right? Into the nodal tissue. So the next topic that I will take, I want you to immediately give the answer. Which anti-diabetic drug primarily reduces hepatic gluconeogenesis? Gluconeogenesis is reduced by only one drug. Very, very important, very common drug. And also they improve the insulin sensitivity. This is also, it's like adding on to the question. It's like adding on to the question. Without causing hypoglycemia. Okay, so glibenclamide, see, in the diabetes, if a drug name is ending with the ide, they can cause hypoglycemia. They are actually sulfonylurea. They are the ATP sensitive potassium channel blocker. They are the ATP sensitive potassium channel blocker. ATP sensitive potassium channel blocker. Metformin is the name of the drug that is going to be an AMP kinase agonist that is inhibiting the gluconeogenesis, plus they are having multiple mechanism of action as well. They also increase the glucose uptake to the muscle because of the insulin sensitizing property. What is pioglitazone? Pioglitazone, they are PPAR gamma agonist. They also increase the insulin sensitivity, but mind the fact they do not inhibit the hepatic gluconeogenesis. Sitagliptin, they are the DPP4 inhibitor. Gliptin, they are all going to be DPP4 inhibitors. Sitagliptin, saxagliptin, alogliptin, right? They are the DPP4 inhibitor, right? DPP4 inhibitor. All right. Next topic lenge. Which antibiotic? Okay, now which antibiotic inhibit bacterial protein synthesis by inhibiting the 50S ribosomal subunit? All right. So gentamicin, they are the aminoglycosides. I told you they are the 30S inhibitor. Tetracycline, again, they are tetracycline itself. They are also going to be 30S inhibitor. They are going to be tRNA inhibitor. T for tetracycline, T for amino acid, tRNA inhibitor. Okay. Erythromycin, they are going to be the macrolides. So they inhibit the translocation. Yes, macrolides are mainly going to be the translocation inhibitor. Currently, you are in your FMG era. That is, you want to clear this exam to go to your internship or PG era. So I always say, if you want to enter from UG to PG era, you have to do line say MCQ. ट्रांसलोकेट करना चाहते हो ना आप, ट्रांसलोकेट करना चाहते हो यूजी से पीजी में, ट्रांसलोकेट करना चाहते हो. नाउ this translocation from which side to which side they are talking about, A side to P side is being inhibited, acceptor side to P side is being inhibited. So this is going to be drug like your linezolid, macrolide like erythromycin, azithromycin, clindamycin, and quinpristine, dalfopristine. Quinpristine and dalfopristine, right? So correct answer for this one is actually going to be macrolide, because ciprofloxacin, they are the fluoroquinolone DNA gyrase inhibitor, right? A very famous question, very favorite question of the examiner. Floxacin, fluoroquinolone, they are associated with foot wala problem. Footballer में foot wala problem, they can actually lead to tendonitis and arthropathy, and this tendonitis and arthropathy, they actually lead to something called your tendon rupture. So what do I say? I say footballer में foot wala problem. What do I say? Footballer में foot wala problem, right? It will be fluoroquinolone, and this fluoroquinolone is ending with the floxacin. Lot of F word is coming here. And a lot of F word is coming. Your examination is not going to be easy, but believe me, it is not going to be difficult also. If you have done your part even once or twice, if you have revised, you'll be able to crack this like a nutshell, very very easily. अखरोट के जैसे तोड़ के आओगे आप इसको, है ना? तो you expect a good conceptual question. You don't expect ABCD wala question or very easy kind of question. है ना? This is the examination that is being produced or being created by the government mindset of our country. The same examination, same mindset that we have in our medical colleges. है ना? So you expect this kind of question, and anyone who is solving very easy question and expecting easy question, right? What is the fun in that, है ना? जैसे एक शायर ने बड़ी अच्छी बात बोली भी है कि नसीब जिनके ऊंचे और मस्त होते हैं, नसीब जिनके ऊंचे और मस्त होते हैं, इम्तहान भी उनके जबरदस्त होते हैं, है ना? तो आपका इम्तहान होगा भी जबरदस्त, है ना? और जबरदस्त एग्जाम करने के बाद जो कॉन्फिडेंस रहेगा ना, बिलीव मी यू विल बी एट अ डिफरेंट लेवल यार, है ना? आप पूछिए अपने सीनियर से जो एग्जाम क्लियर किए हैं, दे आर एट अ डिफरेंट ऑरा, है ना? इन वेयर एवर दे आर गोइंग, है ना? झंडे गाड़ रहे हैं बच्चे. नेक्स्ट क्वेश्चन इज गोइंग टू बी अबाउट a patient with acute organophosphate poisoning present with the salivation, bronchospasm, bradycardia. Okay, so we understand organophosphate is going to be irreversible acetylcholine esterase inhibitor that will cause too much availability of acetylcholine. What drug should be administered to immediately counteract muscarinic symptom? Now look at this question. The question that was asked, immediately counteract muscarinic symptom, you will be giving atropine, which is going to be non-selective muscarinic antagonist. Do you guys know in the very recent examination, in the very recent examination of INI-CET, they asked which drug will be given to reactivate. So pralidoxime, they are the oximes. Pralidoximes, they are going to be the oxime. They are known as acetylcholine esterase reactivators, and they are going to be utilized in the organophosphate poisoning only, OP only, organophosphate poisoning cases only. They are going to utilize only and only in the organophosphate poisoning, pralidoxime, obidoxime, all those, right? Neostigmine, physostigmine, remember what are they? Neostigmine, physostigmine, these are going to be reversible acetylcholine esterase inhibitors. So they are going to increase the level of acetylcholine. So this will worsen the symptom of the patient. So never give cholinergic drug because there is already too much acetylcholine here. Okay. Next question. Which calcium channel blocker predominantly act on the cardiac conduction and is useful in the supraventricular tachycardia? Quickly, you guys can give me the answer. Which of the following is predominantly acting on the conduction? That means nodal tissue pain, and they're utilizing SVT, supraventricular tachycardia. The name of the drug, although I have told you during the anti-arrhythmic classification, the name of the drug is called verapamil, diltiazem. They are going to be the class 4 anti-arrhythmic drug. They are the drug of choice in supraventricular tachycardia. They are also the drug of choice for paroxysmal supraventricular tachycardia in patients with the history of bronchial asthma. In bronchial asthma history, we should not be using adenosine. Adenosine can worsen. Okay. Amlodipine, nifedipine, they are going to be DHPs, dihydropyridines. They are actually associated with the reflex tachycardia. I mean, can you give a drug to a patient who is already having arrhythmia and this drug is causing reflex tachycardia? The answer is no, right? Even same like felodipine also, they are going to be associated also with the reflex tachycardia, right? Reflex tachycardia. There is one by the name of cilnidipine, that is going to be your L-type calcium channel blocker. In addition to that, there are also N-type calcium channel blocking property. Because of that, they will have less risk or no risk of reflex tachycardia. This was the recent INI question. No or less risk of reflex tachycardia, that is going to be cilnidipine. Verapamil is the drug of choice for SVT and PSVT in a bronchial asthma patient, that is also verapamil. A very recent drug that got approved in this one by the name of etripamil. Etripamil is a very recent drug It's available intranasal for the self-administration. Self-administration is possible for PSVT patient. For the PSVT, paroxysmal supraventricular tachycardia patient, whenever it happens, they have to, they can take it easily. Okay. Okay. Next one. Which antipsychotic drug is most commonly associated with hyperprolactinemia? Antipsychotic drug. Hyperprolactinemia will be mainly seen due to D2 blockade, because what we know that dopamine is actually having inhibitory action. Dopamine is actually having inhibitory action on the prolactin. When you are going to give a D2 blockade, the level of prolactin will automatically increase. There is no one to inhibit now, the level of prolactin will automatically increase. So D2 blocker will be mostly associated with hyperprolactinemia. Clozapine, risperidone, olanzapine, quetiapine, they are all atypical antipsychotic. But among the atypical, there is a very dangerous drug, and that drug is very, very risky. And the name of the drug is risperidone. I very fondly call it as a risperidone. It's a very, very risky drug. It's a very, very risky drug, risperidone. It is going to be the most potent atypical. It is going to be the most potent atypical antipsychotic. AP is antipsychotic, most potent atypical antipsychotics. They have 5-HT2A blocking property, plus they have very potent D2 blocking property as well. And because of this D2 blocking property, this is the atypical, this is one of the atypical which is maximally associated with, this is the atypical which is maximally associated with extrapyramidal symptom and hyperprolactinemia. Boys and girls, remember, usually atypicals are not supposed to cause hyperprolactinemia or extrapyramidal symptom, but if someone is causing, they are going to be very, very risky, and this, the name of the drug is called risperidone. Risperidone. Olanzapine, quetiapine will have lesser, much lesser risk, right? Now, since this is one topic that we are discussing, what is one important side effect that is associated with atypicals? See, atypicals are known to cause metabolic syndrome, like dyslipidemia, insulin resistance, hyperglycemia, all those, right? Weight gain and all. Those are going to be there. Clozapine is having overall least to no risk of extrapyramidal symptom. No risk of extrapyramidal symptom. Among the given one, the correct answer is going to be a risky drug, risperidone. Usually, this extrapyramidal symptom, hyperprolactinemia, the most commonly it is associated with D2 blocker, that is called typical antipsychotics. Next one, which of the following is selective COX-2 inhibitor? Remember, COX-2 inhibitor, they will always be ending with a coxib, like celecoxib, rofecoxib, valdecoxib. This celecoxib, they are going to be safe COX inhibitor in patients with the history of peptic ulcer disease, because on GI we have COX-1 mainly, that is having protective role, and they increase the risk of MI, myocardial infarction risk will be increased. That is why they are having black box warning. They are usually having black box warning for causing MI. In states, these COX-2 inhibitors are not utilized. Celecoxib, and there are so many coxib, rofecoxib, valdecoxib, etoricoxib, है ना, etoshine के नाम से अवेलेबल होता है. Aspirin is not a coxib. What is aspirin then? Aspirin is one of the COX-1 inhibitor, and they are having antiplatelet property mainly at the lesser dose. They are not COX-2, antiplatelet action. Ibuprofen is going to be non-selective COX inhibitor. Indomethacin also is going to be non-selective COX inhibitor. COX-2 is all going to be coxib. COX-2 like celecoxib, rofecoxib. Which anticoagulant directly inhibit? I think this question also I have told you that hirudine, lepirudine, bivalirudine, and these are utilized in the treatment of DVT, and they are also utilized the drug of choice for HIT syndrome, heparin induced thrombocytopenic thrombocytosis syndrome. Heparin induced thrombocytopenic, right? That is direct thrombin inhibitor. They are direct inhibitor. Remember, even the direct thrombin inhibitor like Hirudin and all, they are injectable, but this is going to be in per ORM. Heparin, Warfarin, they are anticoagulants. They are anticoagulants. Anticoagulants. Warfarin is oral and heparin is going to be injectable. Rivaroxaban is going to be direct 10A inhibitor. Direct 10A inhibitor. Rivaroxaban. Look at the name. 10A पे बैन लगाने वाला drug. 10A पे बैन लगाने वाला drug. Rivaroxaban. Rivaroxaban. Hello everyone. ठीक है? Yes, absolutely correct. Crystal Medicos. Okay, correct answer for this one will be dabigatran. One very important question that I can squeeze down here. If there is overdose of dabigatran, we can utilize edarucizumab, a monoclonal antibody, edarucizumab. So we always say edarucizumab, dabigatran, dabake daru, edarucizumab, dabake daru, edarucizumab. They are the monoclonal antibody, right? Humanized monoclonal antibody. Next one, a first-line drug for open-angle glaucoma that reduce the intraocular pressure by increasing the uveoscleral outflow. See, uveoscleral outflow is increased by PGF2 alpha analog and alpha 2 agonist like apraclonidine, bremonidine. They are having actually dual action. They decrease production also. And PGF2 alpha inhibitor like latanoprost, bimatoprost, prost. The correct answer is this one. Timolol is a non-selective beta blocker. They can decrease the aqueous production. Yes. Pilocarpine is going to be M3 agonist. They can increase the trabecular outflow, but not uveoscleral. They can increase the trabecular outflow. Acetazolamide, dorzolamide, they are carbonic anhydrase inhibitor. They can also decrease the aqueous production. They can decrease the aqueous production as well. All right. Latanoprost, है ना? Latina नहीं होता है, latano होता है. Latina का मतलब अलग होता है. Latina is someone from Latin. Your Latina, when you say, you are talking about a Latin girl, है ना? It's latanoprost. The important side effect that we know for PGF2 alpha analog is as simple as PGF2 alpha. PGF2 ka side effect is PGF2 alpha. How simple is that? This is known as your pigmentation of iris. That is going to be hyperchromic iritis. Growth of eyelashes. That is going to be hypertrichosis. Then there is going to be foreign body sensation. The patient will actually feel foreign body sensation. Fat atrophy of the orbit. So there is a fat actually in the orbit for the cushioning effect. And because of the fat atrophy, they would lead to enophthalmos. See how simple is it? Enophthalmos. And A for acute uveitis. Right? तो फार्मा इससे आसान और क्या होगा यार? PGF2 alpha का side effect, PGF2 alpha, and this pigmentation of iris, latanoprost was one of the question that was asked in January 2025. So as I said, एक क्वेश्चन से अगला क्वेश्चन निकल के आता है, right? From previous question, the next question come, right? Send me the option Crystal Medicos. Okay, we'll take the next one. Which antibiotic is contraindicated in children because it deposits in teeth and bone? How easy is that? Teeth. Tetracycline. Doxy is the only one which is tetracycline. That is why this doxycycline is going to be avoided in pregnancy and also in the pediatrics less than 10 years. The name of the drug is called tetracycline, and all the tetracycline, they are ending with the doxycycline. Next question. Which of the following drug competitively block angiotensin 2 ka, look at the name, AT1 receptor. So simply all the AT1 receptor are ending with a sartan. Again, very simple question. Just by looking at the question, you can easily give the answer. Sartan, that is going to be AT1 inhibitor. That is going to work by GQ, inhibit the calcium influx into the vessel. Enalapril, they are the ACE inhibitor. Aliskiren, they are the direct renin inhibitor. Spironolactone, they are going to be aldosterone receptor blocker. Spironolactone, they are going to be aldosterone receptor blocker. So correct answer for this one will be losartan. Now let me squeeze down some important information here as well. As I told you that one slide, one very important. Losartan, just by looking at the name of the drug, they are angiotensin receptor blocker. It actually lowers the blood pressure, undoubtedly. It lowers the blood pressure there because they're antihypertensive. Plus, it lowers the uric acid level. It lowers the uric acid level because of their uricosuric property. They mainly cause uric acid ka excretion. It also lowers the platelet aggregation. It lowers the platelet aggregation because of the COX-1 inhibiting property. Because of the COX-1 inhibiting property, right? Lowers the, sorry, thromboxane A2 again. COX-1 will be leading to thromboxane A2. So they would actually lead to thromboxane A2 inhibiting property. Thromboxane A2 will be inhibited, lowers the platelet aggregation, lowering the uric acid, lowering the platelet. So it's all going to be losartan, losartan. Everything is going to be low about losartan. Which drug is used in the acute gout and works by inhibiting microtubule polymerization? So this microtubule polymerization, can you give me the answer just by looking at the name? Can you give me the answer to this question? That is going to be your colchicine actually. So two important things. Colchicine is going to inhibit the chemotaxis and inhibit the microtubule polymerization. They are utilized mainly in the acute gout. Probenecid, they are the uricosuric drug. That means they increase the uric acid excretion. They increase the uric acid ka excretion. Uricosuric drug increasing the uric acid excretion. Probenecid, uricosuric drug, and they are mainly utilized in chronic cases. They are utilized in chronic cases. Febuxostat, they are going to be xanthine oxidase inhibitor, a drug of choice. They are also the xanthine oxidase inhibitor, a drug of choice in chronic gout. Right? This will also be utilized in chronic gout. A best alternative to allopurinol. So the only one that is used in the acute gout is colchicine. Next one, which of the following antibiotic is bactericidal and inhibit bacterial cell wall synthesis? Chloramphenicol, they are going to be 50S inhibitor, that is going to be a protein synthase inhibitor. Protein synthase inhibitor, inhibiting the enzyme peptidyl transferase. Inhibiting the enzyme peptidyl transferase. And because of that, remember, chloramphenicol, it will not allow the peptide bond formation with the newer amino acid that is formed. Peptidyl transferase inhibitor. Amoxicillin is one of the cell wall inhibitor. Erythromycin is a macrolide. They are going to be static. Also 50S inhibitor. Clindamycin is also 50S inhibitor. That is going to be your translocation inhibitor as well. I think I have already given you all the translocation, that if you want to translocate from this stage to a PG state, you have to do a lot of MCQ. Linezolid, macrolide, clindamycin, quintillistin, dalfopristin, right? A preferred drug for hyperthyroidism during first trimester. Again, pregnancy में two important things that you need to see: hyperthyroidism or anticoagulation during pregnancy. Hyperthyroidism, anticoagulation during pregnancy, and one more very important question: malaria during pregnancy. है ना? Hyperthyroidism, malaria during pregnancy, and anticoagulation during pregnancy. Very, very favorite question of the examiner. Nowadays, I don't know. Somehow they are asking this. Which of the following drug is preferred for treatment of hyperthyroidism during first trimester? During first trimester, if it is pregnancy, propylthiouracil. Two important question. The important mechanism, thyroid peroxidase inhibitor, and it inhibits peripheral T4 to T3 conversion. But if the question will be like second, third trimester, remember, they are the drug of choice in second, third trimester. Methimazole, and the pro-drug of methimazole is going to be carbimazole. Radioactive nuclide, radioactive iodide you will not be giving. Levothyroxine, why will you give levothyroxine if there is already a hyperthyroid case? In hyperthyroid case, you need to give anti-thyroid drug. Which anti-malarial drug eradicate hepatic hypnozoids in Vivax and OVAL? Vivax and OVAL, why do you want to eradicate this one? Because remember, for the इरेडिकेशन थेरेपी, है ना, we call it radical cure. We call this one radical cure because in Plasmodium vivax and oval there is a stage of the parasite that is called hypnozoite stage. Hypnozoite stage. Are you all with me? Hypnozoite stage. So the only one that will be working here is primaquine. Mind the fact with the doses that I'm writing that primaquine you are going to give 15 milligram on the daily basis for a total duration of 2 weeks, right? For total duration of 2 weeks. Artemisinin, undoubtedly the drug of choice for Plasmodium falciparum. Chloroquine, my dear students, they have developed resistance, widespread resistance. Quinine is one of the heme polymerase inhibitor that can also be utilized in different kind of malaria, including malaria in pregnancy also, right? But for the hypnozoid state, that is hepatic hypnozoid, we have primaquine, right? A very, very important drug. Drug that I would like to squeeze down, if the examiner is taking question from I and I set, somewhere around 2020, 2021, 2020 or 2021 May, there was a question that there is a drug from the same group is called tefenoquine. So it's a very tough guy and it's my favorite drug. The tough guy is my favorite drug, tefenoquine. It is the derivative or it is considered the congener of primaquine. It is having very high volume of distribution. Mind the fact, any drug if it is having high volume distribution, the T half life is going to be relatively longer. High volume of distribution की वजह से the half life will be somewhere around 2 weeks, and therefore in a very single dose of tefenoquine we can do the radical cure. We can do the radical cure in the single dose because the half-life is much longer. So tefenoquine is my favorite drug because they're the tough guy, right? It's the tough guy, right? Tough guy, tefenoquine. Tough guy, tefenoquine. है ना? धीरे धीरे मेहनत करते रहिए और फिर जितने लोग आप पे सवाल कर रहे थे उन सबके सवालों का जवाब देना है, ढंग से जवाब देना है, और जवाब मैसेज में कॉल पे नहीं देना है, रिजल्ट से देना है ना? रिजल्ट ही आपका बेस्ट जवाब है। जितने लोगों ने आप पे डाउट किया था, आप सभी के लिए आपको बस अपने आप को लेके चलना है। जितने लोग आप पे डाउट कर रहे हैं सिर्फ एक ही चीज उसका जवाब देना, एक ही बेहतर जवाब है, बेस्ट जवाब है, दैट इज योर रिजल्ट। थोड़ा सा अपने चीजों में बदलाव लाइए, अपने शेड्यूल्स में बदलाव लाइए, राइट? PYQs को सॉल्व करने का तरीके में थोड़ा बदलाव लाइए, एंड बिलीव मी यू गाइस आर गोइंग टू नेल इट लाइक अ प्रो, है ना? आजकल धूप का मौसम चल रहा है और आपके ऊपर भी ये धूप ही है, समझ लीजिए। तो जरा ये धूप ढल जाए तो पूछेंगे हाल, है ना? जरा ये धूप, अभी जो प्रॉब्लम चल रहा है ना, जरा ये धूप ढल जाए तो पूछेंगे हाल, यहाँ कुछ साए अपने आप को खुदा बताते हैं, है ना? कुछ साए मतलब ऐसे घूमते फिरते लोग अपने आप बहुत महान समझते हैं ना। तो धूप ढल जाए तो सब एक बराबर आ जाएंगे। तो ये धूप आपके ऊपर भी थोड़ा सा गहरा है ना? और अगर आपको समझ में आ जाए ये बात तो जो मैंने बोला अभी। चलिए आगे देख लेते हैं, 4-5 क्वेश्चन हो रहे हैं। विच ड्रग इज एंटीडोट फॉर मेथनॉल पॉइजनिंग? मेथनॉल पॉइजनिंग वी आर गोइंग टू यूज फॉर्म में पीता था, फॉर्मेपिजोल, दैट इज गोइंग टू अल्कोहल डिहाइड्रोजिनेज इनहिबिटर, राइट? मेथनॉल और एथिलीन ग्लाइकोल दोनों का सेम है। नैलोक्सोन इज द एंटीडोट फॉर ओपियोइड पॉइजनिंग। अ पेशेंट इज ब्रॉट फ्रॉम रेलवे ट्रैक स्ट्रीट, है ना, ओपियोइड ओवरडोज के लिए। एट्रोपिन इज फॉर ऑर्गेनोफॉस्फेट एंड कार्बामेट पॉइजनिंग, कार्बामेट एंड organophosphate poisoning, and protamine is for heparin overdose. Heparin overdose. All other hematology antidotes I have given you already. All right. Which drug is used for reversal of non-depolarizing neuromuscular blockade? Reversal of non-depolarizing, that is going to be drugs like your D-tubocurarine, curare drug, curarine, D-tubocurarine, that is going to be what? The curare drug. So for the reversal we'll be using what? Neostigmine, and साथ में we are going to give atropine as well. We are going to give atropine as well. Why atropine? Mainly to mask the parasympathetic side effect. Parasympathetic side effect. To mask the parasympathetic side effect, we are going to give what? To mask the parasympathetic side effect, we are going to give this one. All right. Are we all good here? Hi everyone. Atropine alone is not going to be the correct answer. Succinylcholine itself is a depolarizing muscle relaxant. Depolarizing muscle relaxant. They are very short lasting. Rocuronium, they are also non-depolarizing muscle relaxant. So how can you give rocuronium in the overdose of a same group of drug? Which drug is the first line for the acute pulmonary edema due to left ventricular failure? So wherever there is acute congestion, you will always using furosemide. Digoxin is actually the drug that is going to be sodium, potassium, ATPase inhibitor at the cardiac myocyte, and because of that there will be increase in the intracellular calcium that will increase the force of contraction. That is inotropic drug, that is digoxin. Atenolol is a beta blocker. Hydrochlorothiazide is a very slow acting diuretic. Slow acting should not be utilized. B is not the answer for this one, Prashant. It is actually going to be the fast acting. Wherever you want decongestion, rapid decongestion, like there is a pulmonary edema, there is a rapid congestion here, rapid decongestion. If you want to do, you need to give faster acting, especially there is a case of heart failure. Fluid load को कम करना पड़ेगा. Anti-arrhythmic drug that prolongs the action potential duration. I have already taught you this. Soda blocks potassium channel. Any drug that is having potassium channel blocking property can cause this one. Lignocaine, like to phone me, the brave group of people, that is going to be class 1B. Queen Prince, class 1A. That is sodium blocker and potassium blocker. Not only potassium blocker. Here it's asking only potassium channel blocker. Amiodarone is a pure potassium channel blocking property. They are class 3 anti-arrhythmic drug. That is going to be the correct answer. Amiodarone. Amiodarone is actually one of the drug. Amiodarone, all-time favorite question of the examiner as well. It is the drug of choice for most cases of the ventricular tachycardia. They are associated with multiple problem like your thyroid abnormality. Hypo most common compared to hyperthyroidism. Hypo. They can also lead to pulmonary fibrosis. This pulmonary fibrosis is a very serious kind of side effect. It's a very serious side effect. They are highly hepatotoxic drug. Can cause QT prolongation as well. Right? Can cause QT prolongation as well. Corneal microdeposits. All these important side. There are so many side effects, just important ones I'm writing. Okay. Examiner asks a patient is on amiodarone. Which investigation is asked on the follow-up? Which investigation you will be asking on follow-up? Because they are causing hepatotoxicity, you should keep an eye on the LFT. They are causing QT prolongation, you should keep an eye on the ECG. They are causing thyroid abnormality, you should keep an eye on the thyroid function test, or simply serum TSH would also do. Right? Because they are causing pulmonary fibrosis, you can do HRCT or simple spirometry would also do. Right? So this is a clinical question. Investigation that is asked on the follow-up. Right? So I always say, let's keep an eye on this. Right? Let's keep an eye on this. LFT, ECG, TFT or TSH and HRCT. Let's keep an eye on this. All right. 28-year-old frequent migraine attack. Propranolol is a class 2. They are the beta blockers. So that I have already told you. A 28-year-old patient with a frequent migraine attack has a history of bronchial asthma. Migraine, I just gave you this question. And there is a history of bronchial asthma. Migraine and bronchial asthma. Remember, which of the following commonly used first line prophylactic should be avoided? Okay, so in bronchial asthma, remember, you should not be giving non-selective beta blocker. This is a very, very simple question. This is non-selective beta blocker. Mind the fact, non-selective beta blocker are going to be contraindicated in. They are going to be contraindicated in bronchial asthma and COPD. They are contraindicated in peripheral vascular disease like Raynaud's, and they are also contraindicated in diabetics because they can mask the hypoglycemic symptom of diabetes. Next exam, the question will be, the patient is having migraine and history of glaucoma. Topiramate can precipitate angle closure glaucoma and renal stone. They can cause renal stone as well. amitriptyline is one of the TCA, flunarizine is one of the calcium channel blocker. They are safer, right? But in a history of bronchial asthma, what is avoided? That is going to be propranolol is avoided. Topiramate is also safe in asthmatic patient. Which oral hypoglycemic agent increase insulin secretion by closing? So I think I have already explained this to you. ATP sensitive potassium channel is by sulfonylurea, and all the sulfonylurea they end with the ide, peptide wala ide. Pioglitazone, they are going to PPAR gamma agonist, increasing the insulin sensitivity. They are associated with increase in the risk of bladder cancer. So remember, bladder cancer, two important questions related to the cancer in anti-diabetic drug. Anti-diabetic drug, that is GLP-1 analog, exenatide, they can cause medullary carcinoma thyroid. And exenatide, lixisenatide, that is going to be GLP-1 analog. They are going to cause medullary carcinoma of thyroid risk. And bladder cancer, pioglitazone. A-carbos, they are the alpha glucosidase inhibitor. A-carbos is going to be alpha glucosidase inhibitor. Mainly they have GI related side effect like flatulence, malabsorption. Metformin is one of the drug of choice for diabetes. They are the AMP kinase agonist, inhibiting gluconeogenesis. We have covered all this in the previous questions. All right. Yes, propranolol is a drug of choice in the prophylaxis of migraine. Propranolol is considered as a drug of choice. मैंने migraine पढ़ाया तो था थोड़ी देर पहले. I taught migraine a while ago. It's a drug of choice for prophylaxis of migraine. Which antiviral drug is nucleoside NRTI, nucleoside reverse transcriptase inhibitor? One is called efavirenz. This is called NNRTI, non-nucleoside reverse transcriptase inhibitor. Ritonavir, Navir drug, they are all going to be the protease inhibitor. Zidovudine is a nucleoside reverse transcriptase inhibitor. That is the correct one. Maraviroc is going to be HIV virus entry inhibitor by targeting GP41 inhibitor. They are the Maraviroc. Okay. Which drug is used as chelating agent in iron overload, such as thalassemia? So thalassemia, there is going to be recurrent blood transfusion, and due to the recurrent blood transfusion, there will be high risk of causing iron overload. So in that case scenario, you will be giving oral iron chelator. That is going to be deferoxamine. D-penicillamine is for copper, right? Deferoxamine. Deferoxamine. The oral, this is injectable actually. Oral chelator should be preferred, but since it's not there, we can use this one. Oral chelator will be deferiprone. And other one is called your deferasirox. So you have to keep them on the long time and long duration. Deferasirox. All right, deferasirox. So they are the oral iron chelator, mainly preferred, but since given the option that we have, we should be going with the deferox. Last question: which of the following drug is used for the treatment of the organophosphate poisoning and reactivate acetylcholinesterase? This is taken from your book. Which book? We are talking about the same book which we started actually, right? Your Predictor Series book. Anna? So remember this one. This was asked in the recent INI CT as well. Recent INI, that was in May 2026. Same question. Which one can reactivate organophosphate poisoning? So it's going to be oxime. We have covered this already. Atropine for immediate symptomatic management, for antidote, or organophosphate and carbamate. Pralidoxime, obidoxime, they are the oximes. Obidoxime, they are going to be the oxime class of drug. Right? So this is everything about today's session which I wanted to discuss. Although मैंने 2 घंटे बोला था, लेकिन थोड़ा सा आगे बात बढ़ गई तो आपके फायदे के लिए है. बस ये है कि you have to now take it from here onwards, all the 50 topics. We have covered 50 slides, and in that more or less multiple topics, more than 50 topics we have covered, because in some of the topics, some of the questions, there were different options, so that was also discussed. You just have to stay very, very strong फ्रॉम हियर एंड, है ना, विथ योर बेसिक कॉन्सेप्ट एज वेल, है ना. The first thing that I would recommend and advise for you, that stop feeling afraid. डरना बंद करो, डरना बंद करो, कुछ नहीं होगा, डरना बंद करो. स्टॉप फीलिंग अफ्रेड, डरना बंद करो, सबसे पहला चीज, है ना. एग्जाम देना है ना, डॉक्टर बनना है, तो इसमें डरने वाली कोई बात नहीं है, फेस करना है, राइट. अब जो सिर पर आ पड़े हैं तो डरना नहीं है. एक बड़ी फेमस सी लाइन है, एक बड़े फेमस पोएट है रामधारी सिंह दिनकर जी, कि अब जो सिर पर आ पड़े हैं तो डरना नहीं है, जन्मे हैं एक बार तो दो बार मरना नहीं है ना. एक बार जन्मे हैं, एक ही बार मरना है, तो अभी बस इत्मीनान से, बिकॉज जो डर गया सो मर गया, ये भी हिंदी फिल्म का डायलॉग है, आपने सुना होगा. तो अभी आपको बस मेंटली स्ट्रांग रहना है, एंड यू हैव टू कंटिन्यू योर प्रिपरेशन विद द वे दैट यू हैव बीन डूइंग, एंड रिवीजन इज द की. मैंने बताया था कि इस समय पे यू हैव टू बी वेरी वेरी केयरफुल, है ना, कि कश्ती से पाँव उतारने वालों जरा संभल के रहो, बिकॉज, है ना, मिट्टी हमेशा किनारे से खिसकती है. ये बात मैंने बताया था क्लास के दौरान भी. यू हैव टू बी वेरी वेरी केयरफुल, बिकॉज एट दिस पॉइंट ऑफ टाइम इफ यू टेक एनी रॉन्ग डिसीजन ऑफ डूइंग समथिंग बिग, समथिंग एक्स्ट्रा, believe me, it is going to backfire like anything. Whatever you have done it, try to revise the same, right. And this series is going to help you in a way that you have not imagined, because आप 2 घंटे दिए, 2 घंटे में मल्टीपल टॉपिक्स हमने कवर किए. बाकी आप हमसे मिलते रहिए. आप सभी को ईद की बहुत बहुत शुभकामनाएं, बहुत बहुत मुबारकबाद हमारी तरफ से. और ईद इट्स अ फेस्टिवल ऑफ सेक्रीफाइस. आई वॉन्ट यू टू sacrifice some of your habits which is holding you from your own, dream, from the dream of your parents, because someone out there who is not calling you every now and then because they think my kid is studying, right, they are giving you the full time, right, they have sacrificed a lot. This is also called as festival of sacrifice, right? So you have to say you have sacrificed and you are sacrificing, we understand, but guys, our parents sacrifice we cannot match. That is, है ना, अनमैच्ड है. और मैं ज़्यादा बोलूँगा तो हो सकता है आप में से कई लोग रो दोगे, जो कि यूजुअली क्लास में होता है. आई डोंट वांट टू गो इन दैट. आई वांट टू एंड दिस विद अ वेरी वेरी हैप्पी नोट. थैंक यू वेरी मच फॉर अटेंडिंग दिस क्लास. I will see you around. You can connect with me on the social media, Instagram, YouTube, Telegram, wherever you are. You just search for me. I am easily available, right? PDF आपको प्रोवाइड कर दिया जाएगा. एंजॉय करिए. मिलते हैं आपसे आने वाले अगले क्लासेस में. बाय बाय टू ऑल ऑफ यू गाइस. शब्बा खैर. Good night.